Welcome to this audiobook entitled BPS Exam Preparations in Gastrointestinal Disorders. We will first of all discuss gastroesophageal reflux disease, abbreviated as GERD. As a way of definition, 1. GERD is defined by consensus as symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond, into the oral cavity, including larynx or lung. As published in the American Journal of Gastroenterology in 2013, the strength of guideline evidence is rated by the grade system, paying attention to the level of evidence and the strength of evidence. 2. Definition subdivides GERD into the following categories. A. Symptoms without erosions on endoscopy, that is, non-erosive reflux disease. B. Symptoms with erosions on endoscopy, that is, erosive reflux disease. 3. We will now progress to the symptoms of GERD. A. Its typical symptoms include the following: heartburn, also known as pyrosis, regurgitation, acidic taste in the mouth. B. Extraesophageal or atypical symptoms, including chronic cough, asthma-like symptoms, recurrent sore throat, laryngitis or hoarseness, non-cardiac chest pain. Sinusitis, pneumonia, bronchitis, otitis media are less common atypical symptoms. These symptoms require referral for additional testing. C. Alarm symptoms include dysphagia, adenophagia, bleeding, weight loss, choking, chest pain, and epigastric mass. These symptoms warrant immediate referral for more invasive testing. 4. Aggravating factors of GERD include recumbency, gravity, elevated intra-abdominal pressure, reduced gastric motility, e.g., gastroparesis, decreased lower esophageal sphincter tone, abbreviated as LES, tone, e.g., peppermint, caffeine, nicotine, and direct mucosal irritation, e.g., irritating foods, bisphosphonates, NSAIDs. 5. The long-term complications of GERD include esophageal erosion, strictures, obstruction, Barrett esophagus, that is, replacement of squamous epithelial cells with columnar epithelial cells within the lower esophagus, resulting in increased risk of esophageal carcinoma, and reduction in quality of life. B. Let's now discuss the diagnosis of GERD. 1. We will begin with its symptoms. A presumptive diagnosis of GERD can be made given typical heartburn and regurgitation symptoms. Empiric therapy of GERD with a proton pump inhibitor, abbreviated as PPI, is recommended. This is a strong recommendation with a moderate level of evidence. B. Screening for Helicobacter pylori is not recommended. This is a strong recommendation with a low level of evidence. Helicobacter pylori screening is recommended in patients with peptic ulcer disease, a history of a documented peptic ulcer, or gastric mucosa-associated lymphoid tissue, abbreviated as MALT lymphoma. C. Patients with non-cardiac chest pain that is suspected to be due to GERD should have a diagnostic evaluation before institution of therapy. This is a strong recommendation with a low level of evidence. 2. Regarding endoscopy, upper endoscopy is not necessary in the presence of typical GERD symptoms. Endoscopy is recommended in the presence of alarm symptoms and in the screening of patients at high risk of complications. Repeated endoscopy is not indicated in patients without Barrett esophagus in the absence of new symptoms. This is a strong recommendation with a moderate level of evidence. 3. Manometry refers to testing to determine esophageal pressure is recommended for preoperative evaluation, but it has no role in the diagnosis of GERD. This is a strong recommendation with a low level of evidence. 4. We will now briefly look at ambulatory pH testing. A. Ambulatory esophageal reflux monitoring is indicated before considering endoscopic or surgical therapy in patients with non-erosive reflux disease as part of the evaluation of patients who are refractory to PPI therapy and when the diagnosis of GERD is in question. This is a strong recommendation with a low level of evidence. B. Ambulatory reflux monitoring is the only test that can assess reflux symptom association. This is a strong recommendation with a low level of evidence. C. Ambulatory reflux monitoring is not necessary in the presence of short or long segment Barrett esophagus to establish a diagnosis of GERD. This is a strong recommendation with a moderate level of evidence. C. We will now discuss the treatment strategies for GERD. 1. Non-pharmacologic interventions and lifestyle modifications are unlikely to control symptoms in most patients. The American College of Gastroenterology guidelines, abbreviated as ACG guidelines, cite insufficient evidence to advocate lifestyle modifications for all patients. Rather, they advocate use in targeted populations. Thus, the following lifestyle modifications should be implemented only in the patient population specified. A. Dietary modifications if symptoms are associated with certain foods or drinks. Routine global elimination of food triggers is not recommended. This is a conditional recommendation with a low level of evidence. 1. Patients should avoid aggravating foods and beverages. Some may reduce LES pressure, e.g., alcohol, caffeine, chocolate, citrus juices, garlic, onions, peppermint, and spearmint, or cause direct irritation, e.g., spicy foods, tomato juice, and coffee. 2. Patients should reduce fat intake. High-fat meals slow gastric emptying. They should also reduce portion size. 3. Patients should avoid eating 2 to 3 hours before bedtime. 4. Patients should remain upright for 2 hours after meals. B. Patients should adopt a weight loss strategy if overweight or have undergone recent weight gain. This is a conditional recommendation with a moderate level of evidence. C. We should reduce or discontinue nicotine use in patients who use tobacco products. Nicotine and tobacco affect LES. D. Patients should elevate the head of the bed and avoid meals 2 to 3 hours before bedtime if they experience nocturnal symptoms. This is a conditional recommendation with a low level of evidence. E. Patients should avoid tight-fitting clothing. This action decreases intra-abdominal pressure. F. Patients should avoid medications that can reduce LES pressure, like the alpha-adrenergic antagonists, calcium channel blockers, anticholinergics, theophylline, benzodiazepines, and opiates, or delay gastric emptying like the opiates, tricyclic antidepressants, calcium channel blockers, and progesterone, or cause direct irritation like the NSAIDs, aspirin, and corticosteroids. 2. Next we will look at pharmacologic therapies of GERD. A. The initial treatment of GERD depends on the severity, frequency, and duration of symptoms. 1. Regarding step-down treatment, it entails starting with maximal therapy, such as therapeutic doses of PPIs, which is always appropriate as a first-line strategy in patients with documented esophageal erosion. Advantages of this strategy include the following: there is rapid symptom relief, and avoidance of over-investigation. The disadvantages include potential overtreatment, higher drug cost, and increased potential for adverse effects. 2. Regarding the step-up treatment strategy, it entails starting with lower dose over-the-counter (OTC) products for patients with less severe symptoms without evidence of esophageal erosion. Its advantages include the fact that it avoids overtreatment, and has lower initial drug cost. Its disadvantages include potential undertreatment, that is, there is partial symptom relief, it may take longer for symptom control, and it may lead to over-investigation. B. The ACG treatment guideline recommendation summary follows in Table 1. Briefly pause the video and carefully scrutinize Table 1 summarizing American College of Gastroenterology Treatment Guideline Recommendation. C. We will now look at antacids. 1. Calcium, aluminum, and magnesium-based products are available OTC in a variety of formulations. That is, capsules, tablets, chewable tablets, and suspensions. 2. Neutralizing acid and raising intragastric pH results in decreased activation of pepsinogen and increased LES pressure. It has a rapid onset of action but short duration of action, necessitating frequent dosing. 3. Some products, e.g. Gaviscon, also contain the anti-refluxant alginic acid, which forms a viscous layer on top of gastric contents to act as a barrier to reflux. It has variable added efficacy. 4. They are used as first-line therapy for intermittent, that is less than twice-weekly symptoms, or as breakthrough therapy for those on PPI or histamine 2 receptor antagonist, abbreviated as H2RA. Therapy. They are not appropriate for healing established esophageal erosions. 5. Regarding adverse reactions, they may cause constipation due to the aluminum component, diarrhea due to the magnesium component, accumulation of aluminum and magnesium in renal disease with repeated dosing. 6. Their drug interactions include chelation of some products, e.g., fluoroquinolones, and tetracyclines, reduced absorption because of increases in pH of some products, e.g., ketoconazole, intraconazole, iron, atazanavir, delavirdine, indinavir, and nelfinavir. D. Regarding the H2RAs. 1. They reversibly inhibit histamine 2 receptors on the parietal cell. 2. All these agents are available as prescription and/or OTC products, a variety of formulations available. Generics exist for all prescription products. See Table 2 for available H2RA formulations. Briefly pause the video and carefully scrutinize Table 2 summarizing histamine 2 receptor antagonists. 3. OTC H2RAs can be used for on-demand therapy for intermittent mild to moderate GERD symptoms. Preventive dosing before meals or exercise is also possible. Higher prescription doses are often necessary for more severe symptoms or for maintenance dosing. The prolonged use is associated with the development of tolerance and reduced efficacy, referred to as tachyphylaxis. 4. H2RAs are less effective than PPIs in healing erosive esophagitis. 5. Regarding their adverse effects, most of them are well tolerated. Central nervous system effects such as headache, dizziness, fatigue, somnolence, and confusion are the most common. Older adults and patients with reduced renal function are at higher risk. Prolonged cimetidine use is associated rarely with gynecomastia. 6. Regarding the drug interactions, they can affect the absorption of drugs dependent on lower gastric pH, e.g., ketoconazole, itraconazole, iron, atazanavir, delavirdine, indinavir, and nelfinavir, or increases in absorption leading to potential toxicity, e.g., raltegravir, and sakinavir. Cimetidine also inhibits cytochrome P450 (CYP) enzymes 1A2, 2C9, 2D6, and 3A4. Warfarin, theophylline, and other agents metabolized by these enzymes can be affected. Cimetidine can also compete with medications and creatinine for tubular secretion in the kidney. We will now discuss proton pump inhibitors. 1. They irreversibly inhibit the final step in gastric acid secretion, and to a greater degree of acid suppression achieved and typically longer duration of action than H2RAs. 2. They are the most effective agents for short and long-term management of GERD and for management of erosive disease. 3. They are the most costly agents. Several PPIs are available as generic prescription strength products, e.g., omeprazole, lansoprazole, and pantoprazole. Omeprazole, lansoprazole, and esomeprazole are available OTC. The OTC products are considered safe and effective for intermittent short-term, that is 2 weeks use in patients with typical heartburn symptoms. Long-term use of OTC products should be discussed with prescriber to prevent loss of follow-up or to assess for potential over- or undertreatment. 4. They are most effective when taken orally before meals. For divided dosing, give evening dose before evening meal instead of at bedtime. See Table 3 for available PPI products and Table 4 for alternative PPI administration options. Briefly pause the video and carefully scrutinize Table 3 summarizing proton pump inhibitors. Briefly pause the video and carefully scrutinize Table 4 summarizing alternative administration of PPIs. 4. Regarding the adverse reactions of PPIs, A. Overall, they are well tolerated. The possible adverse effects include headache, dizziness, nausea, diarrhea, and constipation. Their long-term use is not associated with significant increases in endocrine neoplasia or symptomatic vitamin B12 deficiency. As an option, the 2013 AGA guidelines list the switching of PPIs in patients having adverse effects. This is a conditional recommendation with a low level of evidence. A summary of major adverse effects of PPIs, and prevention and management strategies can be found in Table 5. Briefly pause the video and carefully scrutinize Table 5 summarizing summary of major adverse effects of PPIs, and prevention and management strategies. 5. Regarding drug interactions of PPIs, A. They cause inhibition of CYP450. Omeprazole inhibits the metabolism of substrates, such as diazepam, through CYP2C19 inhibition. 1. There is potential reduced effectiveness of clopidogrel through inhibition of CYP2C19-mediated conversion to active metabolite by omeprazole. Recommendations from the U.S. Food and Drug Administration (FDA) are to avoid omeprazole and to use pantoprazole as an alternative. The 2013 ACG guidelines consider the PPI-clopidogrel interaction not clinically significant. This is a strong recommendation with a high level of evidence. 2. Interaction with high-dose intravenous methotrexate. The labeling for both intravenous methotrexate and the PPIs has been updated to include this interaction, which places patients at higher risk of methotrexate toxicity. Proposed mechanisms include reduced methotrexate excretion by PPI inhibition of BCRP, breast cancer resistance protein, an efflux pump that transports methotrexate across membranes, or reduced renal excretion by inhibition of renal H plus K plus ATPase. Patients receiving high-dose intravenous methotrexate should avoid PPI use with a switch to ranitidine if needed. Holding the PPI dose for 2 days before and after methotrexate administration can prevent the interaction. B. Drugs with pH-dependent absorption, e.g., ketoconazole, itraconazole, and protease inhibitors. F. We will now look at promotility agents. 1. The 2013 guidelines state that prokinetic therapy or baclofen should not be used in patients with GERD without diagnostic evaluation. This is a conditional recommendation with a moderate level of evidence. 2. Metoclopramide is a dopamine antagonist, which is dosed several times a day. It is associated with adverse effects such as dizziness, fatigue, drowsiness, extrapyramidal symptoms, abbreviated as EPS, and hyperprolactinemia. 5 and 10 mg ODT formulations are now available. They are used for GERD and diabetic gastroparesis. 3. Bethanacol is a cholinergic agonist which is poorly tolerated because of adverse effects such as diarrhea, blurred vision, and abdominal cramping. It may also increase gastric acid production. G. Regarding surgical therapy. 1. Surgical therapy, laparoscopic Nissen fundoplication, is a treatment option for long-term therapy in patients with GERD. It has a strong recommendation with a high level of evidence. 2. Surgical therapy is generally not recommended in patients who do not respond to PPI therapy. It has a strong recommendation with a high level of evidence. 3. Surgical therapy is an effective as medical therapy for carefully selected patients with chronic GERD when performed by an experienced surgeon. It has a strong recommendation with a high level of evidence. 4. Patients with obesity contemplating surgical therapy for GERD should be considered for bariatric surgery. Gastric bypass would be the preferred operation in these patients. It has a conditional recommendation with a moderate level of evidence. 5. Current endoscopic therapy or transoral incisionless fundoplication cannot be recommended as an alternative to medical or traditional surgical therapy. It has a strong recommendation with a moderate level of evidence. D. We will now move on to the management of dyspepsia, which was recently reviewed by the American College of Gastroenterology and the Canadian Association of Gastroenterology. The recommendations include endoscopy for patients at risk for serious outcomes, testing and eradicating Helicobacter pylori, and using PPIs, tricyclic antidepressants, prokinetic agents, and psychotherapy to manage symptoms. We will now advance to peptic ulcer disease. A. Classification of peptic ulcer disease, abbreviated as PUD. 1. Regarding duodenal ulcer, A. Its common causes include Helicobacter pylori infection, which accounts for 95% cases, NSAIDs, and low-dose aspirin. B. Its uncommon causes include Zollinger-Ellison syndrome, hypercalcemia, granulomatous diseases, neoplasia, infections e.g. cytomegalovirus, herpes simplex, tuberculosis. C. Regarding its presentation, the following are reported: epigastric pain, possibly worse at night. Often, pain occurs 1 to 3 hours after a meal and may be relieved by eating. Pain may also be episodic. Associated symptoms can include heartburn, belching, a bloated feeling, nausea, and anorexia. 2. Regarding gastric ulcer A. Its common causes include NSAIDs, and Helicobacter pylori infection. B. Its uncommon causes include CD infections caused by cytomegalovirus, and herpes simplex. C. Regarding its presentation, the following are reported: epigastric pain, often made worse by eating. Associated symptoms may include heartburn, belching, a bloated feeling, nausea, and anorexia. 3. The complications of PUD include A. Bleeding, B. Gastric outlet obstruction, and C. Perforation. 4. Patients are at risk of NSAID-induced GI toxicity. Risk factors for NSAID-induced GI complications can be found in Table 6A. Some NSAIDs such as ibuprofen, diclofenac, and nabumtone are intrinsically less toxic to the GI tract than naproxen, which is considered a moderate risk. Other agents such as piroxicam, indomethacin, and ketorolac are considered high-risk agents. B. Duration of NSAID use, higher risk in first 3 months. The presence of chronic debilitating disorders, such as rheumatoid arthritis or cardiovascular CV disease, could also contribute to the increased GI toxicity of NSAIDs, but these are not generally considered independent risk factors. C. Helicobacter pylori infection is thought to confer additive risk of GI toxicity in NSAID users. Briefly pause the video and carefully scrutinize Table 6 summarizing risk factors for NSAID-induced gastrointestinal complications. 5. Regarding its diagnosis A. We pay attention to symptom presentation. B. We do testing for Helicobacter pylori infection. Practitioners must be willing to treat if test results are positive, because Helicobacter pylori is a known carcinogen. 1. Testing is indicated for patients with active ulcer disease, history of PUD, or gastric MALT lymphoma. 2. The Helicobacter pylori test and treat strategy is also acceptable for patients with unevaluated dyspepsia without alarm symptoms who are younger than 60 years. C. Regarding diagnostic tests for Helicobacter pylori infection. 1. Non-invasive tests are preferred over invasive tests for ease of use. A. Serologic tests include the following: Quick View Helicobacter pylori GII, and FlexSure HP. They detect immunoglobulin IgG to Helicobacter pylori in the serum by enzyme-linked immunosorbent assay. They are 85% sensitive, and 79% specific. Using these tests, we cannot distinguish between active infection and past exposure. Because antibodies persist for long periods after eradication, we cannot use them to test for eradication after treatment. B. Urea breath test, abbreviated as UBT, breath tech UBT, PY test, detects the exhalation of radio-labeled carbon dioxide after the ingestion of 13C or 14C radio-labeled urea. Helicobacter pylori hydrolysis of the radio-labeled urea results in carbon dioxide production. It is 97% sensitive, and 95% specific. It is used to make a diagnosis and to test for eradication. Recent use of antibiotics or PPIs can cause false negative results in up to 40% of patients. Patients should discontinue anti-secretory agents or antibiotics at least 2 weeks before UBT testing or wait 4 weeks after treatment has ended before having the UBT performed. C. Stool antigen tests, which include Premier Platinum HPSA, Immunocard Stat. HPSA are polyclonal or monoclonal antibody tests that detect the presence of Helicobacter pylori in stool. They are 88% to 92% sensitive, and 87% specific. They can be used to make a diagnosis and to confirm eradication. Recent use of bismuth, antibiotics, or PPIs, can also cause false negative results. Patients should discontinue anti-secretory agents or antibiotics at least 2 weeks before stool antigen testing or wait 4 weeks after treatment has ended before having the stool antigen test performed. 2. Invasive endoscopic tests are used less frequently than non-invasive tests. A. Histology is 90% to 95% sensitive, and 98% to 99% specific, subject to sampling error. B. Rapid urease tests, Campylobacter-like organism (CLO) test, HP Fast, and Pylori Tech detect the presence of ammonia in a sample generated by Helicobacter pylori urease activity. It is 80% to 95% sensitive, and 95% to 100% specific. False negative results can be caused by a partly treated infection, GI bleeding, achlorhydria, or use of PPIs, H2RAs, or bismuth. Patients should discontinue anti-secretory agents for at least 1 week before the test is performed. C. Culture is costly, time-consuming, and technically difficult. It is 100% specific. B. We will now discuss the treatment of Helicobacter pylori-associated ulcers. 1. General recommendations, based on the American College of Gastroenterology (ACG) guidelines, are to include an anti-secretory agent, preferably a PPI, plus at least 2 antibiotics, that is, clarithromycin and amoxicillin or metronidazole, in the eradication regimen. Specific treatment regimens are listed in Table 7. 2. Quadruple therapy with bismuth subsalicylate, metronidazole, tetracycline, or doxycycline in the case of drug shortages, and a PPI is considered an alternative first-line treatment. Pylera, a quadruple-based therapy formulated with tetracycline, bismuth subcitrate, and metronidazole in 1 capsule, can be used by patients with aspirin allergy. 3. Sequential therapy involves administration of a PPI and amoxicillin given first for the first 5 days, followed by a PPI clarithromycin, and tinidazole for an additional 5 days. This therapy requires further validation before widespread use will be accepted. 4. A bismuth-based quadruple therapy for 14 days or a levofloxacin-based triple therapy for 10 days can be used in patients who have not responded to initial regimens as salvage therapy. 5. Follow-up testing for eradication should be performed in patients with a history of ulcer complication, MALT lymphoma, early gastric cancer, or recurrence of symptoms. 6. UBTs, or stool antigen tests, are preferred for confirming eradication. We should wait at least 4 weeks after treatment for both. Briefly pause the video and carefully scrutinize Table 7 summarizing recommended treatment regimens for Helicobacter pylori infection. C. We will now discuss primary prevention of NSAID-induced ulcers. 1. We should implement risk factor modification. 2. We should test and treat for Helicobacter pylori infection if the patient is beginning long-term NSAID therapy. 3. We should determine the level of GI-related risk, whether low, medium, or high, using Table 6. See Box 1 for strategies to prevent GI complications in patients receiving NSAIDs based on the cardiovascular risk. 4. Because of the association of increased risk of cardiovascular events with NSAID use, the patient's cardiovascular risk should be determined as well. The ACG guidelines define those at high cardiovascular risk as patients who require low-dose aspirin for the prevention of cardiac events. Naproxen is the only NSAID that does not appear to increase the risk of cardiovascular events, therefore, its use is preferred in patients with cardiovascular risk factors per the ACG guidelines. However, in February 2014, an FDA panel voted against label changes that would indicate a lower cardiovascular thrombotic risk. This can be accessed at the following website, www.fda.gov/advisory-committees/calendar/UCM380871.htm. Pause the video and carefully scrutinize Box 1 summarizing preventive strategies based on risk of NSAID-related GI complications and cardiovascular risk. 5. Misoprostol, marketed as Cytotec, should be given at full doses of 800 micrograms per day in 4 divided doses. However, this therapy is poorly tolerated because of excessive nausea, vomiting, diarrhea, and abdominal cramping. 6. Let's now look at concomitant use of antiplatelet agents and NSAIDs. A. The need for antiplatelet therapy should first be evaluated. B. If antiplatelet therapy is deemed necessary, assess for the presence of GI risk factors, as shown in Table 6. Dyspepsia or GERD symptoms are additional risk factors. C. Test and treat for Helicobacter pylori in patients with a history of a non-bleeding ulcer and in those with a history of an ulcer-related complication. Eradicating Helicobacter pylori before beginning long-term antiplatelet therapy is optimal. DPPIs are the preferred gastroprotective agents for both treatment and prevention of aspirin and NSAID-associated GI injury. Gastroprotective therapy should be prescribed for patients with GI risk factors who require the use of any NSAID, including OTC and cyclooxygenase 2 COX-2 inhibitors, in conjunction with low-dose aspirin. Gastroprotective therapy should be prescribed for patients with GI risk factors who require low-dose aspirin. Aspirin doses greater than 81 mg per day should not be used in patients with GI risk factors during the long-term phase of aspirin therapy. GPPIs should be prescribed for patients receiving concomitant aspirin and anticoagulant therapy, that is, unfractionated heparin, low molecular weight heparin, argatroban, warfarin, direct oral anticoagulants, and fondaparinux. Age. The target INR range of 2 to 2.5 should be used in patients for whom warfarin is added to concomitant aspirin and P2Y12 inhibitor, e.g., clopidogrel, prasugrel, ticagrelor therapy. The combination of both aspirin and clopidogrel with warfarin should be used only when benefit outweighs risk. Clopidogrel is not recommended as a substitute for patients with recurrent ulcer bleeding. Aspirin plus a PPI is superior to clopidogrel for GI bleed risk. J. The healthcare provider, who decides to discontinue aspirin therapy in patients with short-term bleeding episodes should weigh the risks of subsequent GI or cardiac events. K. For patients receiving dual antiplatelet therapy, that is aspirin plus clopidogrel, who require elective endoscopy, for example particularly colonoscopy and polypectomy, consider deferring if patient is at high risk of cardiac events. Elective endoscopy should be deferred for 1 year after the placement of drug-eluting stents. D. We will now discuss the treatment and secondary prevention of NSAID-induced ulcers. 1. We should do risk factor modification. 2. We should discontinue or lower NSAID dose, if possible. Ulcers will heal with appropriate treatment, but healing may take longer with continued NSAID use. 3. We should test for Helicobacter pylori and treat, if present. 4. Regarding drug therapy, PPIs are the drugs of choice for healing and secondary prevention of NSAID-induced ulcers. The combination product, marketed as Vimovo, contains esomeprazole with naproxen in the same tablet, 375 mg plus 20 mg or 500 mg plus 20 mg, but may be expensive. B. Misoprostol appears to be as effective as PPIs for healing and secondary prevention, however, it necessitates several doses per day, and it is poorly tolerated because of the high incidence of diarrhea and abdominal pain. C. COX-2 inhibitors like celecoxib was shown to have rates of ulcer recurrence and bleeding comparable to those of a diclofenac plus omeprazole combination. The use of celecoxib may be limited by its association with cardiovascular effects. The use of celecoxib is also uncertain in combination with low-dose aspirin for secondary prevention of GI events. D. The combination of a COX-2 inhibitor and a PPI is not well studied, but it can be considered in high-risk patients, especially if receiving aspirin plus steroids or warfarin or have a history of a recent complicated GI event and require continued NSAID or aspirin use. EH2RAs are inferior to misoprostol and PPIs in healing and preventing recurrence. Clopidogrel is not recommended as a substitute in patients with recurrent ulcer bleeding. Aspirin plus a PPI is superior to clopidogrel for GI bleed risk. 5. We will briefly consider the cardiovascular safety of COX-2 inhibitors and NSAIDs. A. The main theory underlying the development of excess thrombotic events with COX-2 inhibitor use is that when COX-2-mediated prostacyclin production is reduced, the prothrombic prostaglandin thromboxane A continues to be produced by COX-1, leading to the development of a prothrombic state. B. Celecoxib was not associated with increases in cardiovascular events until the adenoma prevention with celecoxib trial for cancer prevention was terminated in 2004. Daily doses of 400 and 800 mg of celecoxib conferred a 2.5-fold and 3.4-fold higher risk of fatal and non-fatal MI, respectively, which suggests a dose-related response for this toxicity. C. The AHA recommends a stepped approach for patients with cardiovascular disease or risk factors for ischemic heart disease who require analgesic treatment of musculoskeletal symptoms. 1. We should consider using acetaminophen, aspirin, tramadol, or short-term narcotics first. 2. Non-acetylated salicylates, e.g., salsalate, choline, magnesium trisalicylate, can be considered next. 3. Non-COX-2 selective NSAIDs can be used next, followed by NSAIDs with some COX-2 activity. Use the lowest possible effective dose. 4. Celecoxib should be reserved as a last resort. In patients at increased risk of thromboembolic events, co-administration with aspirin and a PPI can be considered. 5. Routinely monitor blood pressure, renal function, and signs of edema or GI bleeding. D. Methods to reduce cardiovascular risk, such as tobacco cessation, blood pressure reductions, lipid control, and glucose control, are recommended for NSAID users, but have not been proved to reduce NSAID-associated cardiovascular risk. In patients for whom the risk of GI bleeding outweighs the cardiovascular risk, lower-risk NSAIDs such as ibuprofen, etidolac, diclofenac, or celecoxib should be used. In patients for whom the cardiovascular risk outweighs the risk of GI bleeding, COX-2 inhibitors should be avoided. Limit the dose and therapy duration, if possible. The AHA recommends that ibuprofen be taken at least 30 minutes after or 8 hours before the ingestion of immediate-release low-dose aspirin to prevent the ibuprofen from attenuating the antiplatelet effects of the aspirin. In 2014, an FDA panel voted against label changes to indicate lower cardiovascular thrombotic risk with naproxen than with other NSAIDs, despite a 2013 meta-analysis showing that naproxen had a lower cardiovascular risk than high-dose diclofenac and ibuprofen. This was published in The Lancet in 2013. Let's briefly look at upper GI bleeding. We will begin with the causes of upper GI bleeding. They include the following: 1. Peptic ulcer disease, 40% to 70%, due to NSAIDs and low-dose aspirin use or Helicobacter pylori. 2. Esophagitis. 3. Erosive disease. 4. Esophageal varices. 5. Mallory Weiss tear, which are longitudinal mucosal lacerations in the lower esophagus or upper stomach. 6. Neoplasm. 7. Stress ulcers in critically ill patients. We will now discuss its clinical symptoms and presentation. They include 1. Hematemesis or coffee ground emesis. 2. Hematochezia. 3. Nausea and vomiting. 4. Melena. 5. Shock manifesting as tachycardia and clammy skin. 6. Hypotension. 7. Associated organ dysfunction, that is, renal, hepatic, cardiac, cerebral hypoperfusion. Briefly pause the video and carefully scrutinize Box 2 summarizing clinical predictors of death associated with non-variceal upper GI bleeding and Box 3 summarizing predictors of persistent or recurrent upper GI bleeding. We will now discuss the management of ulcer-related GI bleeding. 1. Let's first look at volume resuscitation and hemodynamic stabilization. It begins with the placement of 1 or 2 large-bore intravenous catheters. This is followed by fluid replacement with crystalloids such as 0.9% normal saline is preferred. Colloids such as blood can be given after initial resuscitation in patients with hemoglobin of less than 7 grams per deciliter to maintain a hemoglobin concentration of 8 to 10 grams per deciliter. 2. We will now discuss risk stratification. It should be based on the following: A. Clinical signs and symptoms. B. Use of clinical scoring scales such as Blatchford or Rockall scores to determine the risk of early rebleeding and the need for urgent versus non-emergency intervention. Patients with low risk of rebleeding can be discharged after endoscopy. Placing an NG tube for aspiration can be considered but is not required. Endoscopy should be done within 24 hours if possible. Consider doing it within 12 hours in patients with high-risk clinical features. E. Assessment of comorbid illnesses, like liver disease, coagulopathies, cardiac status. F. Predictive factors of death with upper GI bleed are listed in Box 2. Predictors of persistent or recurrent GI bleeding are listed in Box 3. 3. We will now look at endoscopic therapy. A. Endoscopic therapy is associated with reductions in rebleeding, the need for surgery, and mortality. Perform it within 12 to 24 hours of presentation. B. Observation of low-risk stigmata, that is a clean-based ulcer or a non-protuberant pigmented dot in an ulcer bed, is not an indication for hemostatic therapy. C. Clots visible in an ulcer bed should be irrigated, with treatment of underlying lesions. D. The presence of high-risk stigmata warrants immediate hemostatic therapy. 4. Regarding endoscopic strategies, A. The combination of injection and coaptive therapy is the most efficacious. The use of either technique plus pharmacotherapy is superior to monotherapy. B. Regarding sclerotherapy, no single solution for injection is superior to another. They include the following. 1. Epinephrine with or without ethanolamine is inferior by itself. We should combine it with another endoscopic therapy. 2. Cyanoacrylate. 3. Thrombin. 4. Sodium tetrahedrosyl sulfate. 5. Polydocanol. C. Regarding thermal coaptive therapy, no single method is superior to another. They include 1. Heater probe thermocoagulation. 2. Multipolar electrocoagulation. 3. Laser coagulation is not often used because of cost. 4. Argon plasma coagulation. D. Placement of hemostatic clips. 5. We will now look at pharmacotherapeutic management of non-variceal upper GI bleeding. A. Remove medications that are contributing to bleeding, e.g., NSAIDs. B. Pre-endoscopic erythromycin, 250 mg intravenously, can be considered to improve diagnostic yield, but this has not been shown to improve outcomes. This is a conditional recommendation. C. Regarding PPI therapy. 1. The use of a pre-endoscopic dose, which is 80 mg intravenous bolus, followed by an 8 mg per hour intravenous infusion of PPI may be considered. This does not result in reduced mortality, surgery, or rate of rebleeding, but it can reduce the lesion size, the possibility of finding a high-risk lesion, and the need for endoscopic therapy. PPIs may be given if endoscopy will be delayed or cannot be performed. 2. Bolus 80 mg plus a continuous infusion of 8 mg per hour for 72 hours after endoscopic therapy for patients with active bleeding or non-bleeding visible vessel or with adherent clot. Intravenous pantoprazole or esomeprazole can be used. Most data are with intravenous omeprazole. This is used in Europe. 3. It is associated with decreases in rebleeding, mortality, and need for surgery in patients with active bleeding who have undergone successful endoscopic intervention. 4. Oral once-daily PPI therapy can be used for patients with a flat spot or clean-based ulcer. E. The use of H2RAs, or octreotide, marketed as somatostatin, is not recommended. F. Test for Helicobacter pylori and treat if results are positive. If results are negative, then retest. There is no need for a PPI after eradication. G. Assess the need for continued secondary prevention with PPI therapy. If needed, a single daily oral dose of a PPI is recommended. H. Assess the need for NSAID or aspirin use. If NSAID therapy is needed, then use of a COX-2 inhibitor plus a PPI is recommended, barring any significant cardiovascular risk. Otherwise, a PPI should be used. If the use of low-dose aspirin is required, reinitiate when cardiovascular risk is thought to outweigh GI risk. Use a PPI and reinitiate aspirin within 1 to 3 days, if not within 1 week. Clopidogrel has a higher rate of rebleeding than aspirin. J. Long-term PPI therapy is recommended for ulcers not associated with NSAIDs or Helicobacter pylori. D. We will now look at prophylaxis of SRMD in critically ill patients. 1. Stress-related injury is a superficial diffuse upper GI ulceration. 2. Stress ulcer is a deeper mucosal ulceration. It may lead to bleeding and hemodynamic compromise. 3. Contributing factors to SRMD development include the following: A. Hypoperfusion of the GI tract. B. Altered susceptibility to gastric acid. C. Loss of defense mechanisms, that is the mucus or bicarbonate layer, prostaglandins, cellular renewal. D. Alterations in gastric motility, which may affect absorption of drugs. 4. Let's briefly look at pharmacologic prevention. A. It is not routinely recommended in non-intensive care unit settings. B. It is recommended in patients in an intensive care unit with the risk factors in Box 4. Pause the video and carefully scrutinize Box 4 summarizing the risk factors for initiation of prophylaxis for SRMD in intensive care units. 5. Preventive treatment options include the following: A. Antacids. They require several oral doses per day or administration by enteral tube. Diarrhea, constipation, and electrolyte abnormalities are possible. B. Sucralfate 1. It provides a direct mucosal barrier. It modulates pepsin, mucus activity, bicarbonate secretion, and tissue growth repair. 2. It requires many oral doses or administration by enteral tube. It may lead to aluminum accumulation and constipation. There is a possibility of binding to other drugs in the GI tract. It has no effect on platelet count and is associated with lower rates of pneumonia development. 3. The general efficacy regarding bleeding is considered similar to that of H2RAs. C. Regarding the H2RAs. 1. They reduce gastric acid secretion by inhibition of histamine stimulation of the parietal cell. There is development of tolerance or tachyphylaxis with continued use. 2. They are considered efficacious in the prevention of clinically significant bleeding. Oral, intravenous intermittent dosing, and continuous infusion are all possible options. High-dose intravenous ranitidine, cimetidine, or famotidine use can be considered first-line therapy. Cimetidine is the only H2RA that is FDA approved for SRMD prevention. 3. They are associated with CNS adverse effects and the rare development of thrombocytopenia. They require adjustment for renal dysfunction. D. We will now move on to proton pump inhibitors. 1. The American Society of Health System Pharmacists guidelines include minimal recommendations for PPI use because of the lack of data at that time. However, PPIs are commonly used for SRMD prevention. 2. PPIs are similar to H2RAs in safety and efficacy. 3. Oral or intravenous routes may be used. Alternative formulations exist for patients with difficulty swallowing or with feeding tubes. See section on GERD. 4. Oral PPIs are as efficacious as intravenous PPIs for maintaining equivalent pH. 5. Intravenous PPI therapy is generally considered equivalent to high-dose intravenous H2RA therapy. 6. There are associations with Clostridioides difficile infections in hospitalized patients. We will now shift gears to inflammatory bowel disease. A. Background 1. Inflammatory bowel disease, abbreviated as IBD, includes both ulcerative colitis, abbreviated as UC, and Crohn's disease, abbreviated as CD. In some instances, UC may be indistinguishable from CD, and can be called indeterminate or intermediate colitis. 2. Regarding its pathophysiology, the exact cause of continuing inflammation of the GI mucosa is unknown, but it is thought that the inflammation is secondary to an antigen-driven response. 3. The contributing factors include a. Defects in the intestinal epithelial barrier and immune system. B. There is a definite genetic association. First-degree relatives of affected patients have a 4 to 20-fold greater risk of developing IBD. C. Environmental. 1. NSAIDs worsen IBD, probably secondary to alteration of epithelial barrier. 2. Smoking worsens CD, associated with improvement in UC symptoms. 3. Luminal bacteria, endogenous intestinal bacteria, are thought to be highly involved in stimulating the intestinal inflammatory response observed in IBD. 4. Dietary antigens may also contribute to ongoing inflammation. D. Various pro-inflammatory cytokines, including interleukin-1, interleukin-6, and tumor necrosis factor, abbreviated as TNF, contribute to the ongoing inflammatory process. B. Clinical features. 1. Presenting symptoms common to UC and CD include fever, abdominal pain, diarrhea, which may be bloody, watery, or mucopurulent, rectal bleeding, and weight loss. Symptoms can vary depending on disease location. See Table 8 for the clinical features of IBD. Pause the video and carefully scrutinize Table 8 summarizing clinical features of inflammatory bowel disease. 2. We will now discuss the systemic manifestations of IBD. A. Both UC and CD can present with concurrent systemic manifestations. B. Hepatobiliary manifestations include primary sclerosing cholangitis, cholangiocarcinoma, hepatitis, cirrhosis, cholelithiasis, steatosis. C. Rheumatologic arthritis, sacroiliitis, and ankylosing spondylitis. D. Dermatologic manifestations include erythema nodosum, aphthous ulcers, and pyoderma gangrenosum. E. Ocular manifestations include iritis or uveitis, and episcleritis. 3. We will briefly tackle gauging clinical severity. A. Ulcerative colitis severity can be determined using Table 9, based on Truelove and Witt criteria. B. Regarding Crohn's disease. 1. In mild to moderate cases, patients tolerate oral administration, there is an absence of fever, dehydration, and abdominal tenderness, and there is less than 10% weight loss. 2. Moderate to severe cases, failed treatment of mild to moderate anemia, nausea and vomiting, or considerable weight loss usually present. 3. In severe cases there is no response to outpatient steroids, they have high temperature, abdominal pain, persistent vomiting, possible obstruction, abscess, cachexia, and rebound tenderness. Briefly pause the video and carefully scrutinize Table 9 summarizing clinical severity of ulcerative colitis. 4. We will now look at general management considerations in IBD. A. We should rule out possible infectious causes of bloody diarrhea in patients with acute symptoms. B. Elevated concentrations of fecal lactoferrin and fecal calprotectin indicate inflammation and help differentiate patients with IBD from those with IBS. These concentrations may also be used to monitor disease activity and therapy response. C. Most patients will undergo colonoscopy to confirm the diagnosis and extent of disease. D. Surgery is a viable option when complications, that is, abscess, fistula, perforation, occur or when fulminant disease is unresponsive to medical treatment. E. Distribution and severity of disease will dictate the initial treatment choice. F. Most patients will require maintenance therapy because of the high incidence of relapse after induction therapy. The relapse rate is 35% to 80% at 2 years for CD and 50% to 70% at 1 year for UC. C. Let's progress to the medical management of IBD. Regarding the adjunctive therapies. 1. We should take caution in active disease. Reduction in motility may precipitate toxic megacolon 2. Loperamide, marketed as Imodium, can be useful for proctitis or diarrhea, dosed at 2 mg after each loose stool, with a 16 mg per day maximum dose. 3. Regarding the antispasmodics, A. Dicyclamine, marketed as Bentyl, is dosed at 10 to 40 mg orally 4 times daily. B. Propantheline, marketed as Probanthine, is dosed at 7.5 to 15 mg orally 3 times daily. C. Hyoscyamine, marketed as Levsin, is dosed at 0.125 to 0.25 mg orally as slow release every 4 hours as needed. 4. Cholestyramine, marketed as Questran, is used possibly for bile salt-induced diarrhea after ileal resection. D. Regarding the medications used to treat IBD-1. The selection of treatment is based on disease location and severity. 2. Let's begin with aminosalicylates A. They are used for both induction and maintenance of remission. B. Sulfasalazine is a prototype agent, marketed as Azulfadine, Azulfadine N. 1. Sulfasalazine is cleaved by colonic bacteria to the active portion, which is 5-aminosalicylate, and the inactive carrier molecule sulfapyridine. 2. Efficacy is best in colonic disease because of colonic activation of the drug. 3. Dose-related adverse effects due to the sulfapyridine portion include GI disturbance, headache, arthralgia, and folate malabsorption. 4. Idiosyncratic adverse effects include rash, fever, pneumonitis, hepatotoxicity, bone marrow suppression, hemolytic anemia, pancreatitis, and decreased sperm production in men. 5. We should avoid it in patients with a sulfur allergy. 6. It is dosed at 4 to 6 grams per day for induction and 2 to 4 grams per day for maintenance therapy. It is available as immediate release and enteric-coated products. Doses should be titrated beginning at 500 to 1000 mg once or twice daily to avoid adverse effects. C. 5-aminosalicylates is a non-sulfur-containing medication. 1. It is generally better tolerated than sulfasalazine. It is first line in mild-moderate UC and CD. 2. Product selection depends on location of disease. The available formulations are listed in Table 10. 3. Olsalazine is associated with secretory diarrhea in up to 25% of patients. 4. There are rare instances of nephrotoxicity with use of 5-aminosalicylates. Briefly pause the video and carefully scrutinize Table 10 summarizing aminosalicylate formulations. 3. Regarding corticosteroids A. They work quickly to suppress inflammation during acute flares. B. They have no role in maintenance therapy. However, more than 50% of patients with severe disease may become steroid dependent. C. Budesonide is about 15-fold more potent than prednisone, because of its high first-pass metabolism and limited systemic exposure, allow a 2-week overlap when changing from prednisone to budesonide to prevent adrenal insufficiency. It is formulated to release in the terminal ileum and treats only terminal ileal and ascending colonic disease. D. Adverse effects of systemic therapy include adrenal suppression, glucose intolerance, hypertension, sodium and water retention, osteoporosis, cataracts, and impaired wound healing. Systemic adverse effects are minimal with budesonide use. Available corticosteroid formulation are listed in Table 11. Pause the video and carefully scrutinize Table 11 summarizing corticosteroid preparations. 4. Let's now discuss immunomodulators used in the treatment of IBD-A. They include mercaptopurine, marketed as purinethol, azathioprine, marketed as Amurin, azarsen, which is a prodrug of mercaptopurine, or methotrexate. B. Their doses are azathioprine 2 to 2.5 mg per kilogram per day orally, mercaptopurine 1 to 1.5 mg per kilogram per day orally, methotrexate 15 to 25 mg per week intramuscularly in CD only. C. They are indicated only for maintenance because of long onset of action, which is 3 to 15 months. D. Regarding their efficacy, the number needed to treat to prevent one relapse of UC or CD is 3 or 4 patients. E. The use can result in a steroid-sparing effect. F. Azathioprine and mercaptopurine are metabolized by the enzyme thiopurine methyltransferase, abbreviated as TPMT. Reduced expression of TPMT can result in slower metabolism and increased toxicity. TPMT activity or TPMT genotype or phenotype should be determined before initiating therapy. G. Regarding their adverse reactions, 1. Azathioprine and mercaptopurine can cause pancreatitis in 3% to 15% of patients, bone marrow suppression, nausea, diarrhea, rash, and possible hepatotoxicity. Risk of hepatosplenic T-cell lymphoma, especially in younger male patients. The risk is greatest if combined with a TNF-alpha antagonist. 2. Methotrexate causes bone marrow suppression, nausea, diarrhea, rash, pulmonary toxicity, and hepatotoxicity. 5. Biologic agent used in treatment of IBD include infliximab, adalimumab, certolizumab, golimumab, natalizumab, vedolizumab, tofacitinib, ustekinumab. Baseline evaluation should be done before their use, including a comprehensive metabolic panel, liver function tests, complete blood cell count. B. Viral hepatitis screening and C. Tuberculosis screening. 6. Regarding infliximab, marketed as Remicade, A. It is a chimeric monoclonal antibody against TNF-alpha. B. It is indicated for both CD and UC, for the treatment of 1. Moderate severe active disease. 2. Fistulizing CD. 3. Maintenance of moderate severe disease. C. It is available as intravenous infusion only. It is expensive. D. Studies of patients whose conventional therapy failed show that clinical response according to disease activity scores is about 40% to 80%. E. Regarding its dosing, in the case of moderate severe active disease or fistulizing disease, it is dosed at 5 mg per kilogram as single dose, followed by 5 mg per kilogram at 2 and 6 weeks, then every 8 weeks as maintenance. Patients losing response with time can be treated with a 10 mg per kilogram dose. F. Regarding its adverse reactions, 1. Infusion-related reactions include hypotension, fever, chills, urticaria, and pruritus. We should infuse it over at least 2 hours. We may pretreat with acetaminophen and/or an antihistamine. 2. Delayed hypersensitivity, manifesting as fever, rash, myalgia, headache, or sore throat 3 to 10 days after administration. 3. Infection, that is reactivation of latent infections, which may be bacterial, including disseminated tuberculosis, fungal, and sepsis. Do not give it to patients with active infections. Tuberculosis should be ruled out before any biologic agents are initiated. 4. Heart failure exacerbations. It is contraindicated in New York Heart Association Class 3 or 4 heart failure. Do not exceed 5 mg per kilogram dose in other patients with chronic heart failure. 5. Regarding antibody induction, up to 50% of patients may develop anti-nuclear antibodies. 19% may develop anti-double-stranded DNA antibodies. 6. It may also cause bone marrow suppression, i.e. pancytopenia. 7. Black box warning applies to all TNF-alpha antagonists. Unusual cancers have been reported in children and teenage patients taking TNF blockers. Hepatosplenic T-cell lymphoma has occurred mostly in teenaged or young adult males with CD or UC who were taking infliximab and azathioprine or mercaptopurine. 8. Hepatitis reactivation of hepatitis B virus HBV, autoimmune hepatitis may also occur. Discontinue use if liver function tests rise to more than 5 times the upper limit of normal ULN. 9. It can also cause vasculitis with CNS involvement. 7. Next we will look at adalimumab, marketed as Humira A. It is a fully humanized antibody to TNF-alpha, therefore, theoretically, there is no development of antibodies. B. It is indicated for both induction and maintenance therapy for moderate to severe active CD and UC in patients unresponsive to conventional therapy. It is also indicated for patients who no longer respond to infliximab. C. Regarding its dosing, induction dose is 160 mg subcutaneously on day 1, given as 4 separate 40 mg injections, or 2 40 mg per day injections for 2 consecutive days, followed by 80 mg subcutaneously 2 weeks later on day 15. Next, we can decrease dose to 40 mg subcutaneously every other week starting on day 29 of therapy. D. Regarding its efficacy, 1. Complete remission rates at week 4 range from 21% to 54%. 2. Efficacy rates for maintenance therapy are 56% to 79% at week 4 and 36% to 46% at week 56. 3. The adverse effect profile of adalimumab is similar to that of infliximab, except for the development of antibodies to adalimumab. 8. Next we will discuss certolizumab, marketed as Cimzia A. It is a humanized monoclonal antibody fragment to TNF-alpha linked to polyethylene glycol, with murine complementary determining regions. B. It is indicated for maintenance therapy for moderate-severe active CD in patients unresponsive to conventional therapy. C. Regarding its dosing, the induction dose is 400 mg subcutaneously, then 400 mg subcutaneously at weeks 2 and 4. A maintenance dose of 400 mg is administered subcutaneously every 4 weeks. D. Regarding its efficacy, 1. Patients with AC reactive protein concentration greater than 10 mg per liter have the best response. Up to 37% response at 6 weeks versus 26% for placebo. 2. Up to 62% of patients with an initial response and AC reactive protein concentration greater than 10 mg per liter may be maintained in remission at 26 weeks. 3. The certolizumab adverse effect profile is similar to that of other TNF-alpha antagonists. 9. We will now discuss golimumab, marketed as Simponi A. It is a human Ig/G1 kappa monoclonal antibody. B. It is indicated for moderate to severe UC in patients intolerant of previous therapies or requiring continuous steroid therapy. C. Regarding its dosing, it is dosed at 200 mg subcutaneously at week 0, 100 mg at week 2, and 100 mg every 4 weeks thereafter. D. Regarding its efficacy, 1. In moderate to severe UC, clinical response at 6 weeks was 51% with golimumab versus 30% with placebo. Clinical remission at 6 weeks was 18% and 6% with golimumab and placebo, respectively. 2. Continued clinical response for 54 weeks was 50% with golimumab and 31% with placebo. E. Regarding its adverse effects, its toxicity profile is similar to that of other TNF-alpha antagonists. 10. And now we will discuss natalizumab, marketed as Tisabri A. It is a humanized monoclonal antibody that antagonizes integrin heterodimers and inhibits alpha-4 integrin-mediated leukocyte adhesion. B. It is indicated for inducing and maintaining clinical response and remission in adult patients with moderate-severe active CD who have had an inadequate response to, or are unable to tolerate, conventional therapies and inhibitors of TNF-alpha. C. Regarding its dosing, 1. Patients must enroll in the TOUCH program before the drug is dispensed because of its association with progressive multifocal leukoencephalopathy. 2. Induction and maintenance doses are both 300 mg intravenously every 4 weeks. If there is no effect after 12 weeks or inability to discontinue steroids within 6 months of beginning therapy, treatment should be discontinued. D. Regarding its efficacy, 1. The ENACT 1 and 2 trials showed similar results for natalizumab and placebo at 10 weeks, 56% versus 49% with a p-value equal to 0.05. However, those who initially responded had rates of sustained response, 61% versus 28% with a p-value equal to 0.001 at week 36. 2. Can also improve quality of life in patients who initially respond after 48 weeks of treatment. E. Regarding its adverse effects, 1. Natalizumab is associated with the development of progressive multifocal leukoencephalopathy. Monitor for mental status changes during treatment. Consider magnetic resonance imaging and lumbar puncture if mental status changes or weakness is observed. 2. Because of a potential for hepatotoxicity, monitor for jaundice or other signs of liver disease. 3. Increased risk of infection. 4. Infusion-related reactions. Observe patient for 1 hour after infusion. 5. The drug should not be used in combination with TNF-alpha inhibitors or immunosuppressants. 11. Let's now discuss vedolizumab, marketed as Entyvio-A. It is a humanized monoclonal antibody that targets alpha-4 beta-7 integrin-mediated leukocyte adhesion. B. It is indicated for use as induction and maintenance therapy for patients with UC and CD for whom other therapies, including TNF-alpha antagonists, have failed. C. Induction and maintenance doses are both 300 mg intravenously given at 0, 2, and 6 weeks and then every 8 weeks. Discontinue if there is no evidence of improvement at 14 weeks. D. The Gemini 1 study showed efficacy in induction and maintenance for moderate-severe UC with a clinical response rate of 47% versus 25% versus placebo at 6 weeks with a p-value less than 0.001. The Gemini 2 study of induction and maintenance of moderate to severe CD showed remission rates of 14.5% versus 6.8% for placebo at 6 weeks with a p-value equal to 0.02. Its safety profile is similar to that of natalizumab, with the exception of a lower risk of progressive multifocal leukoencephalopathy, because vedolizumab's mechanism is more specific for gut-based integrin. There is no required prescribing program. 12. Let's now discuss ustekinumab, marketed as Stelara-A. It is a monoclonal antibody to the p40 subunit of interleukin-12 and interleukin-23, that is, it is an anti-IL-12/23. B. It is indicated for moderate to severely active CD after the failure of corticosteroids, thiopurines, methotrexate, or TNF inhibitors. C. Its induction dosing is 260 mg for patients weighing less than 55 kg, 390 mg for those weighing more than 55 to 85 kg, and 520 mg for those weighing more than 85 kg intravenously at week 0. D. Its maintenance dosing is 90 mg subcutaneously every 8 weeks. E. The Unity 1 study of patients with CD who had received a TNF inhibitor with inadequate response or intolerable adverse effects. The Unity 2 study included patients with active CD and treatment failure or intolerable adverse effects to immunosuppressant or glucocorticoid therapy. Ustekinumab 130 mg dose and a weight-based 6 mg per kilogram dose resulted in response at week 6 more often than placebo. Unity 1 34.3%, 33.7%, and 21.5%, respectively. Unity 2 51.7%, 55.5%, and 28.7%, respectively. P-value less than 0.05 for all comparisons with placebo. Maintenance doses every 8 or 12 weeks resulted in remission at week 44 in 53.1% and 48.8% of patients compared with 35.9% receiving placebo. P-value less than 0.05 versus placebo. F. Its common adverse effects were vomiting with induction therapy and nasopharyngitis, injection site erythema, vulvovaginal candidiasis, bronchitis, pruritus, urinary tract infection, and sinusitis with maintenance treatment. As with other biologic therapies, serious infections include tuberculosis, therefore, screening for tuberculosis is recommended before starting therapy. 13. We will now discuss tofacitinib, marketed as Xeljanz, A. It is an oral Janus kinase inhibitor, abbreviated as JAK inhibitor. B. It is indicated for moderate to severe UC. C. Its induction dosing is 10 mg orally twice daily for at least 8 weeks. D. Its maintenance dosing is 5 to 10 mg orally twice daily depending on response. Discontinue if response is inadequate after 16 weeks of treatment with 10 mg twice daily. E. Regarding dose adjustments, if receiving strong CYP3A4 inhibitor or moderate CYP3A4 inhibitor and a strong CYP2C19 inhibitor, or if moderate to severe renal impairment or moderate hepatic impairment, we should reduce 10 mg twice daily dose to 5 mg twice daily. We should reduce 5 mg twice daily dose to 5 mg once daily. If lymphocyte count or absolute neutrophil count is less than 500 cells per millimeter cubed, discontinue tofacitinib. If absolute neutrophil count is 500 to 1000 cells per millimeter cubed, reduce dose as earlier and resume previous dose when absolute neutrophil count is greater than 1000 cells per millimeter cubed. Interrupt dosing for hemoglobin less than 8 grams per deciliter or a reduction of more than 2 grams per deciliter, and restart dosing when hemoglobin normalizes. F. In the Octave Induction 1 and 2 trials, patients with moderate to severe active UC despite conventional therapy or TNF inhibitor therapy received tofacitinib 10 mg or placebo twice daily for 8 weeks. In Octave 1, 18.5% and 8.2% of patients achieved remission with tofacitinib and placebo, respectively. P-value equal to 0.007. In Octave 2, 16.6% and 3.6% achieved remission, respectively. P-value less than 0.001. Octave Sustain reported remission at 52 weeks in 34.3% of patients receiving 5 mg of tofacitinib twice daily, 40.6% of patients receiving 10 mg twice daily, and 11.1% receiving placebo. P-value less than 0.001. Both comparisons with placebo. G. Tofacitinib has been associated with nasopharyngitis, upper respiratory tract infection, increased blood creatine phosphokinase, and cholesterol concentrations, rash, headache, diarrhea, and herpes zoster. Tofacitinib is also associated with serious infections such as tuberculosis, and patients should be screened before starting therapy. Lymphocytopenia, neutropenia, and low hemoglobin can occur. Check lymphocytes at baseline and every 3 months, and check neutrophil and hemoglobin concentrations at baseline after 4 to 8 weeks of therapy, and then every 3 months. Tofacitinib has also been associated with malignancies and GI perforation. 14. Let's now look at the medical management of UC. The treatment is selected according to disease location and severity. Next are guideline definitions of UC distribution. 1. Distal disease is located distal to splenic flexure. In this case we may use oral or systemic or topical, that is rectal therapy. 2. Extensive disease is located proximal to splenic flexure. It requires systemic or oral therapy. B. In the case of mild to moderate distal disease 1. The first-line therapy is topical, that is an enema or suppositories. Aminosalicylates are preferred. They are superior to oral aminosalicylates and topical corticosteroids. This is a greater evidence. Oral budesonide, marketed as Euceris, can be considered an alternative first-line therapy. 2. Patients who are refractory to oral aminosalicylates or topical corticosteroids may respond to mesalamine enemas or suppositories. 3. Oral mesalamine plus topical mesalamine can be considered. It may be more effective than either agent alone. This is a greater evidence. 4. Patients refractory to the above agents may require 40 to 60 mg of oral prednisone or infliximab given as 5 mg per kilogram intravenously at weeks 0, 2, and 6. 5. We will now look at maintenance therapy. Mesalamine suppositories dosed at 1 gram rectally every day or 1 gram 3 times a week are effective for maintaining remission in patients with proctitis. B. Mesalamine enemas dosed at 2 to 4 grams per day are effective for maintaining remission in patients with distal disease extending to the splenic flexure and can also be given 3 times a week. C. Oral treatment with sulfasalazine, 2 to 4 grams per day, mesalamine 1.5 to 4.8 grams per day, or balsalazide 6.75 grams per day is also effective. D. Combining oral and topical mesalamine is more effective than using either regimen alone. E. Topical steroids have no role in maintenance therapy. F. Nicotine replacement 15 to 25 mg per day transdermally may improve symptoms as an adjunctive therapy. Effects seem to be most beneficial in former smokers. G. Azathioprine, mercaptopurine, infliximab, or adalimumab may be necessary if patients do not respond to aminosalicylate therapy. C. In mild to moderate active extensive disease 1. First-line therapy is oral sulfasalazine dosed at 4 to 6 grams per day, or an alternative aminosalicylate at a dose equivalent to mesalamine 4.8 grams per day, or oral budesonide, Euceris, can be considered as an alternative first-line therapy. 2. Patients who are refractory to the combination of oral and topical aminosalicylate agents may require oral corticosteroids, 40 to 60 mg of prednisone. 3. Azathioprine or mercaptopurine can be used for patients who are unresponsive to oral steroids but not acutely ill enough to require intravenous treatment with infliximab or adalimumab. 4. Infliximab, adalimumab, golimumab, or certolizumab can be used for moderate active disease in patients who are steroid refractory or steroid dependent or are intolerant of, or unresponsive to, azathioprine or mercaptopurine. Vedolizumab or tofacitinib may be considered for patients who have not responded to conventional or TNF inhibitor therapy. 5. Maintenance. Aminosalicylates are the preferred agents for maintenance of remission. B. Patients should not be treated with long-term steroids for maintenance therapy. C. Azathioprine or mercaptopurine are effective steroid-sparing agents for maintenance of remission. They can be used in combination with aminosalicylates. D. Infliximab can be given for maintenance of moderate disease at a dose of 5 mg per kilogram every 8 weeks if patients are initially responsive. Adalimumab can also be used at a dose of 40 mg subcutaneously every 2 weeks. Certolizumab can be used at a dose of 100 mg subcutaneously every 4 weeks. Vedolizumab or tofacitinib may be given as maintenance therapy as well. D. Regarding severe disease, 1. Patients with severe symptoms refractory to oral or topical aminosalicylates or corticosteroids should be treated with a 7 to 10 day course of intravenous corticosteroids, e.g. hydrocortisone 300 mg or methylprednisolone equivalent 60 mg per day. 2. Alternatively, infliximab, adalimumab, certolizumab, vedolizumab, or tofacitinib should be used for severe disease as a next step in therapy. 3. Antibiotics, particularly metronidazole, have mixed results in the treatment of active UC in the absence of infection. The use provides little clinical benefit. Antibiotics can be used in severe colonic disease or for patients with pouchitis. 4. Patients who are refractory to 3 to 5 days of intravenous corticosteroids are candidates for intravenous cyclosporine dosed at 4 mg per kilogram per day. We should target concentration of 350 to 500 nanograms per milliliter, followed by oral therapy at 8 mg per kilogram per day with a target concentration of 200 to 350 nanograms per milliliter if initial response to intravenous cyclosporine is obtained. Adding azathioprine or mercaptopurine to oral cyclosporine has shown better long-term success in maintaining remission, and this should be implemented. 5. Patients who are refractory to the above are candidates for colectomy. 6. Patients with toxic megacolon should undergo bowel decompression, treatment with broad-spectrum antibiotics, and possibly colectomy. Regarding the management of pouchitis, 1. Patients with ileoanal anastomosis who develop symptoms of pouchitis, that is inflammation of the surgically created pouch or artificial rectum after colectomy, which can be treated with metronidazole dosed at 250 mg or 20 mg per kilogram 3 times daily, ciprofloxacin 500 mg twice daily, or the combination of both antibiotics. 2. The recommended antibiotic treatment duration is 2 weeks. Refractory cases of pouchitis may require longer therapy. 3. Use of oral probiotics e.g. Bifidobacterium and Lactobacillus, VSL number 3, may be beneficial in preventing recurrent pouchitis. 15. We will now look at the medical management of CD/A. Treatment is selected according to disease location and severity. B. In mild to moderate active disease, the first line for ileal, ileocolonic, or colonic disease, 1. Oral aminosalicylate, e.g., mesalamine dosed at 3.2 to 4 grams per day or sulfasalazine 6 grams per day, is commonly used but considered minimally effective. 2. Budesonide 9 mg per day is preferred for terminal ileal or ascending colonic disease. 3. Metronidazole 10 to 20 mg per kilogram per day may be used in patients not responding to oral aminosalicylates, but it is generally more effective in patients with perianal or colonic disease. 4. Ciprofloxacin 1 gram per day is considered as effective as mesalamine, generally, second line, but is usually more effective in perianal or colonic disease and is typically used in combination with metronidazole. C. Regarding moderate to severe disease, 1. Corticosteroids e.g. prednisone 40 to 60 mg per day or budesonide 9 mg per day is used if there is terminal ileal involvement, until resolution of symptoms and resumption of weight gain. 2. Anti-TNF-alpha agents in combination with thiopurines are the preferred therapies for induction of remission for moderate to severe CD. Thiopurine monotherapy or methotrexate is not recommended to induce remission in moderate to severe active CD/A. Infliximab 5 mg per kilogram is an alternative first-line treatment with improvement in up to 80% of patients. Infliximab can be combined with azathioprine in patients whose therapy with aminosalicylates and corticosteroids has failed and who are naive to biologic agents. This combination is superior to each drug given alone, however, there is a risk of hepatosplenic T-cell lymphoma. B. Certolizumab 400 mg subcutaneously and then 400 mg subcutaneously at weeks 2 and 4, or adalimumab 160 mg subcutaneously initially followed by 80 mg subcutaneously 2 weeks later, can also be considered, particularly in patients with C-reactive protein values greater than 10 mg per liter. Adalimumab can be used as initial therapy or for patients who no longer respond to infliximab therapy because they developed antibodies to infliximab. 3. Vedolizumab 300 mg or natalizumab intravenously every 4 weeks can be considered for patients who did not respond to any other conventional medical therapy. 4. Ustekinumab 260 to 520 mg intravenously on the basis of patient weight, followed by 90 mg subcutaneously every 8 weeks can be used for patients whose conventional or inhibitor therapy has failed. 5. Methotrexate maintenance therapy, 15 to 25 mg per week intramuscularly or subcutaneously, is effective in patients whose active disease has responded to intramuscular methotrexate and who have steroid-dependent or steroid-refractory disease. D. Regarding severe disease, 1. Severe symptoms despite oral corticosteroids or infliximab therapy. 2. Assess need for surgical intervention, mass, obstruction, and abscess. 3. Administer intravenous corticosteroids, 40 to 60 mg of prednisone equivalent. 4. Parenteral nutrition may be needed after 5 to 7 days. 5. Possibly use intravenous cyclosporine if steroids fail. Regarding maintenance therapy, 1. There is no role for long-term corticosteroid use, but budesonide can be used for up to 3 months in patients with mild to moderate disease with ileal involvement. 2. Azathioprine or mercaptopurine or infliximab, or the combination, can be used after induction with corticosteroids. 3. Azathioprine or mercaptopurine or mesalamine dosed at more than 3 grams per day can also be used after surgical resection to prevent recurrence. 4. Infliximab 5 mg per kilogram at 0, 2, and 6 weeks and then every 8 weeks, or adalimumab 40 mg subcutaneously every other week, starting on day 29 of therapy. 5. Vedolizumab 300 mg or natalizumab intravenously every 4 weeks can be considered for patients who did not respond to conventional medical therapy. 6. Ustekinumab 90 mg subcutaneously every 8 weeks can be used for patients whose conventional or TNF inhibitor therapy has failed. 7. Methotrexate intramuscularly 25 mg for up to 16 weeks, followed by 15 mg per week intramuscularly, is effective for patients with chronic active disease. We will now look at perianal disease. 1. Simple perianal fistulas, that is a single tract without abscess and involving less than 30% of the external sphincter, has a better prognosis. It can be treated less aggressively than complex fistulas. Use the following: A. Antibiotics, like metronidazole or ciprofloxacin. B. Azathioprine or mercaptopurine. C. Infliximab, adalimumab, or certolizumab. 2. Complex perianal fistulas, that is, involving more than 30% of the external sphincter, multiple tracts, abscess involvement, recurrent fistulas, rectovaginal fistulas have a worse prognosis requiring more aggressive therapy than simple fistulas. Treat using A. infliximab, adalimumab, or certolizumab. B. Antibiotics like metronidazole or ciprofloxacin, mainly as adjunctive therapy in this case. C. Azathioprine or mercaptopurine or methotrexate. D. Cyclosporine or tacrolimus. Next we will discuss the complications of liver disease. A. The severity of liver disease is assessed using scoring tools such as the Child-Turcotte-Q or Model for End-Stage Liver Disease, abbreviated as MELD, scores, shown in tables 12 and 13. B. We will begin with ascites. 1. Definition. In this condition there is free fluid in the abdominal cavity owing to increased resistance within the liver, that forces lymphatic drainage into the abdominal cavity, and reduced osmotic pressure within the bloodstream, due to hypoalbuminemia. It develops at a 5-year cumulative rate of 30% in compensated liver disease 2. Its clinical features include protuberant abdomen, shifting dullness, fluid wave, bulging flanks, and abdominal pain. 3. Regarding its diagnosis, it is based on A. Clinical features. B. Abdominal ultrasonography. C. Paracentesis, used to determine serum ascites albumin gradient, abbreviated as SAAG, calculated by subtracting the ascites albumin concentration from the serum albumin concentration. A value greater than 1.1 indicates ascites caused by portal hypertension. Pause the video and carefully scrutinize Table 12 summarizing the Child-Turcotte-Q classification of the severity of cirrhosis and Table 13 summarizing the model for end-stage liver disease, abbreviated as MELD. 4. We will now discuss the treatment of ascites. We can do so by A. Alcohol cessation if it is alcohol-induced. B. Attainment of negative sodium balance. 1. Dietary sodium restriction to less than 2000 mg per day, fluid restriction, that is less than 1.5 liters per day, if serum sodium is less than 120 to 125 millimoles per liter. 2. The goal is sodium excretion greater than 78 millimoles per day. A random spot urine sodium concentration greater than the potassium concentration, ratio greater than 1, correlates with a 24-hour sodium excretion of greater than 78 millimoles per day with 90% accuracy. 3. Regarding diuretics, A combination furosemide and spironolactone is preferred initial therapy in most patients. A ratio of 40 mg of furosemide to 100 mg of spironolactone is an appropriate starting regimen. Amiloride 10 to 40 mg per day can be substituted for spironolactone in patients who develop tender gynecomastia. B. If tense ascites is present, large volume paracentesis can be used. Administer albumin at a dose of 6 to 8 grams for every liter of ascitic fluid removed if more than 5 liters is removed at one time. C. If refractory ascites is present, consider midodrine 7.5 mg 3 times daily as add-on therapy to diuretics. 4. There is no upper limit of weight loss if massive edema is present. 0.5 kg per day is recommended in patients without edema. 5. Monitor for electrolyte imbalances, renal impairment, and gynecomastia if spironolactone is used. C. Discontinue drugs associated with sodium or water retention, such as NSAIDs. Avoid angiotensin-converting enzyme inhibitors and angiotensin receptor blockers to prevent renal failure. C. We will now discuss hepatic encephalopathy. 1. Regarding its definition, hepatic encephalopathy is a brain dysfunction caused by liver insufficiency or portosystemic shunting. It manifests as a wide spectrum of neurological or psychiatric abnormalities ranging from subclinical alterations to coma. A. It is thought to be secondary to the accumulation of nitrogenous substances, mainly ammonia arising from the gut. Overall, ammonia serum concentrations do not correlate well with mental status. B. Other theories are related to the activation of gamma-aminobutyric acid receptors by endogenous benzodiazepine-like substances, possible zinc deficiency, or altered cerebral metabolism. 2. Regarding the clinical features of hepatic encephalopathy and criteria, A. It can result in acute encephalopathy with altered mental status and progress to coma if untreated. Asterixis, that is, hand flap, is a classic physical finding. B. It may be precipitated by various factors including constipation, GI bleeding, infection, hyperkalemia, dehydration, hypotension, and CNS active drugs such as benzodiazepines and narcotics. C. The West Haven criteria and the Glasgow Coma Scale are used to classify and grade it. See Table 14. Pause the video and carefully scrutinize Table 14 summarizing common criteria and clinical symptoms for hepatic encephalopathy. 3. We will now look at the classifications of hepatic encephalopathy. A. It is done into subtypes according to underlying disease. 1. It can be classified as type A owing to acute liver failure. 2. It can be classified as type B owing to portosystemic bypass or shunting. 3. It can be classified as type C owing to cirrhosis. B. It can also be classified basing on duration as follows: 1. Episodic. 2. Recurrent, which occurs within a time frame of 6 months or less. 3. Persistent, which denotes a pattern of behavioral alteration that is always present and interspersed with relapses of overt hepatic encephalopathy. C. It can also be classified basing on the presence or absence of precipitating factors. 4. Regarding its treatment, we should A. Assess need for airway support and remove possible precipitating factors. B. The main treatments are targeted at reducing the nitrogen load in the gut. C. Treatment recommendations are based on type C as illustrated in Table 15. Pause the video and carefully scrutinize Table 15. Treatment of hepatic encephalopathy owing to cirrhosis type C. D. Regarding lactulose. 1. It is a non-absorbable disaccharide, which is metabolized by colonic bacteria to acetic and lactic acid. Ammonia present in the GI lumen is reduced to ammonium ion through the reduction in pH, ammonia trapping, and is unable to diffuse into the bloodstream. Lactulose can also alter bacterial metabolism, resulting in increased uptake of ammonia. 2. Lactulose is dosed at 45 ml orally every 1 to 2 hours until the patient has a loose bowel movement and then titrated to 2 or 3 loose bowel movements per day. That is typically 15 to 45 ml 2 or 3 times daily. Lactulose may also be administered as an enema made up of 300 ml of lactulose plus 700 ml of water retained for 1 hour. Powder formulation, marketed as Crystallose, is available in 10 and 20 grams packets to be dissolved in 120 ml water. 10 grams are equivalent to 15 ml traditional lactulose. This formulation is more palatable than traditional syrup. 3. It can be continued over the long term to prevent recurrent encephalopathy. 4. Flatulence, diarrhea, and abdominal cramping are common adverse effects of lactulose. Regarding the antibiotics used in treatment. 1. They are targeted at reducing the number of intraluminal urease-producing bacteria that can lead to excess ammonia production. 2. Neomycin, 3 to 6 grams per day in 3 or 4 divided doses for 1 to 2 weeks and then 1 to 2 grams per day maintenance, or metronidazole dosed at 250 mg orally twice daily can be used. Neomycin is considered as effective as lactulose. 3. From 1% to 3% of neomycin is absorbed. Caution is required with long-term use with renal insufficiency. Long-term metronidazole can result in peripheral neuropathy. 4. Rifaximin is as effective as lactulose and other non-absorbable antibiotics, and it may be better tolerated. The approved dose for reduction in overt encephalopathy in patients 18 years and older is 550 mg twice daily. Drug cost may be greater, but this may be offset by fewer hospitalizations and shorter lengths of stay. Previous studies in the short-term setting have used 400 mg 3 times daily. Other possible treatments. 1. Polyethylene glycol 3,354 liters given orally or by nasogastric tube over 4 hours resulted in faster improvement in encephalopathy than lactulose. 2. Benzodiazepine antagonists such as flumazenil can be used in cases of possible benzodiazepine overdose. 3. Zinc supplementation should be used in patients with documented zinc deficiency. 4. Branched-chain amino acids and intravenous L-ornithine L-aspartate are alternative or additional therapies in patients who are unresponsive to traditional therapies. 5. Nutritional interventions include 35 to 40 kilocalories per kilogram per day based on ideal body weight and 1.2 to 1.5 grams per kilogram per day protein intake. We will now shift gears to gastroesophageal varices. 1. As a background to this condition, resistance to blood flow within the liver caused by cirrhosis results in portal hypertension. Collateral blood vessels, e.g., esophageal varices, are formed because of this increased resistance to blood flow. Variceal hemorrhage can occur in 25% to 35% of patients with cirrhosis and varices. Mortality rates are as high as 30% to 50% per bleed. Recurrence rates are as high as 70% within the first 6 months after an initial bleed. 2. Regarding the management of acute variceal bleeding, we do fluid resuscitation and hemodynamic stabilization. We should maintain hemoglobin concentration of about 8 grams per deciliter. Administration of fresh frozen plasma or platelet can be considered for patients with considerable coagulopathy. Endoscopy is done to assess the extent of disease with potential intervention. 1. Sclerotherapy stops bleeding in 80% to 90% of patients. It may be associated with complications such as perforation, ulceration, stricture, and bacteremia. Possible sclerosing agents are ethanolamine and sodium tetradecyl sulfate. 2. Endoscopic variceal band ligation can be used as an alternative to sclerotherapy, with fewer complications. We will now discuss the medical management of acute variceal bleeding. 1. Institute after fluid resuscitation before endoscopy, if possible. 2. Most therapies are targeted at reducing splanchnic blood flow and portal pressure. A combination of endoscopic and vasoactive therapies is most effective. 3. Regarding the somatostatin analog, octreotide, it prevents postprandial hyperemia by reducing portal pressure, by reduced splanchnic blood flow, through inhibitory effects on vasoactive peptides such as glucagon, or by a local vasoconstrictor effect. It is the preferred agent in combination with endoscopic interventions because of more favorable adverse effect profiles. The main adverse effects of octreotide include hyperglycemia and abdominal cramping. Octreotide is dosed at 50 micrograms via intravenous bolus, then 50 micrograms per hour intravenously for 3 to 5 days. 4. Vasopressin is dosed at 0.2 to 0.4 unit per minute plus nitroglycerin 40 to 400 micrograms per minute for 3 to 5 days. Vasopressin use results in splanchnic vasoconstriction. It is used less often secondary to the need for both drugs and coronary vasoconstriction or hypertension with vasopressin. Nitroglycerin attenuates these effects to some extent. B. Vasopressin has more adverse effects than octreotide, as therefore, it is overall less preferable. 5. We will now look at the non-drug measures to control bleeding. A. They are typically used for medically unresponsive bleeding. B. Minnesota or Blakemore tube, balloon compression applied directly to bleeding varices. C. Transjugular intrahepatic portosystemic shunt results in shunting of blood from the portal circulation. This may be associated with complications such as bleeding, infection, and increased risk of hepatic encephalopathy. D. Surgery can also be used. 6. Regarding antibiotic therapy, A. The use of oral or intravenous prophylactic antibiotics in patients with cirrhosis with variceal bleeding reduces short-term mortality. These agents should be prescribed. B. Typical regimens include ceftriaxone intravenously 1 gram per day for 7 days, especially when quinolone-resistant bacteria are prevalent or the patient has been receiving quinolone prophylaxis. Fluoroquinolone can be considered in patients who do not have a high risk of quinolone resistance. D. We will now look at the prevention of variceal bleeding. 1. Regarding the primary prophylaxis, A. A screening esophagogastroduodenoscopy is recommended to evaluate for esophageal and gastric varices when the diagnosis of cirrhosis is made. B. Pharmacologic therapy is not recommended to prevent the development of varices in patients with cirrhosis who have not yet developed varices. C. Patients who have small varices and no history of bleeding, but meet the criteria for increased risk of bleeding, child Q class B or C, red whale marks on varices, should receive preventive drug therapy with non-selective beta blockers. D. Non-selective beta blockers can be considered, however, the long-term benefit is unclear in patients who have small varices and no history of bleeding, but who do not meet the criteria for increased risk of bleeding. E. Non-selective beta blockers are indicated in all patients with medium or large varices and no history of bleeding. An endoscopic variceal ligation, abbreviated as EVL, can be used if non-selective beta blockers are contraindicated. F. Mechanism of non-selective beta blockers. Blockade of beta-1 receptors reduces cardiac output, whereas blockade of beta-2 receptors prevents splanchnic vasodilation. Unopposed alpha-1 mediated constriction of the splanchnic circulation also leads to reductions in portal pressure. G. Therapy should aim for a heart rate of 55 to 60 beats per minute or a 25% reduction from baseline. H. Non-selective beta blockers like propanolol, nadolol, carvedilol are associated with a significant reduction in the incidence of first bleed. I. Long-acting nitrates like isosorbide mononitrate or dinitrate should not be used for primary prophylaxis. These agents are believed to decrease intrahepatic resistance and are considered as effective as propanolol. However, there is an increased incidence of mortality in some studies when they are used as monotherapy. J. Shunt surgery or endoscopic sclerotherapy should not be used for primary prophylaxis. 2. Regarding secondary prophylaxis, A. All patients with a history of variceal bleeding should receive secondary prophylaxis to prevent recurrent bleeding. B. A combination of endoscopic variceal band ligation and non-selective beta blockers is considered the most effective regimen. C. Non-selective beta blockers are associated with approximately a 20% reduction in the incidence of variceal rebleeding. Reductions in mortality are minimal and inconsistent between trials. Most studies are of patients with child Turcotte Q class A or B cirrhosis. Class C patients may be unable to tolerate beta blockers. D. Combining non-selective beta blockers with nitrates leads to slightly higher reductions in rebleeding rates. No added mortality benefit is observed, and there is a higher incidence of adverse effects with the combination. Sclerotherapy is no longer recommended for secondary prophylaxis because EVL has been shown to be better, with fewer complications. The transjugular intrahepatic portosystemic shunt is highly effective at preventing recurrent bleeding, however, it is associated with a 30% to 40% incidence of encephalopathy and is reserved for medically unresponsive patients. Contraindications to non-selective beta blockers include asthma, insulin-dependent diabetes with frequent hypoglycemia, and peripheral vascular disease. Adverse effects of non-selective beta blockers include lightheadedness, fatigue, shortness of breath, sexual dysfunction, and bradycardia. Adverse effects of EVL include transient dysphagia, and chest discomfort. We will now shift gears to spontaneous bacterial peritonitis, abbreviated as SBP1. We will begin with a background. As a way of definition, SBP is the infection of previously sterile acidic fluid without an apparent intra-abdominal source. It is considered primary, as opposed to secondary, peritonitis. It may be present in 10% to 30% of hospitalized patients with cirrhosis and ascites. It is associated with 20% to 40% of in-hospital mortality. It has a poor prognosis after recovery, with 2-year survival after initial episode reported at about 30%. Regarding the pathophysiology of SBP, the principal theory is seeding of the acidic fluid from an episode of bacteremia. The bacteria present are usually enteric pathogens. Thus, they may enter the blood because of increases in gut permeability secondary to portal hypertension, suppression of hepatic reticuloendothelial cells, or translocation of the gut wall and dissemination through the mesenteric lymph system. Reduced opsonic activity of the acidic fluid and alterations in neutrophil function may also be contributing factors. Enteric gram-negative pathogens are most commonly involved, and more than 90% of cases involve a single bacterial species. See Table 16. Pause the video and carefully scrutinize Table 16 summarizing most commonly isolated bacteria responsible for spontaneous bacterial peritonitis. We will now discuss clinical and laboratory features of SBP. Clinical presentation can vary. Its common symptoms include fever, abdominal pain, nausea, vomiting, diarrhea, rebound tenderness, and exacerbation of encephalopathy. About 33% of patients present with renal failure, which is associated with significant increases in mortality. GI bleeding and septic shock or hypotension rarely occur. Regarding laboratory results, 1. We may see systemic leukocytosis or increases in serum creatinine. 2. Abdominal paracentesis must be performed. The presence of more than 250 polymorphonuclear cells per millimeter cubed is diagnostic for SBP. Lactate dehydrogenase, glucose, and protein values may help to distinguish it from secondary peritonitis. 3. Blood culture results are positive in 50% to 70% of cases. Acidic fluid culture results are positive in 67% of cases. 4. Gram stain of acidic fluid is typically low yield. 4. We will now discuss the treatment of acute SBP. Because of the high associated mortality, treatment should be initiated promptly in patients with clinical and laboratory features consistent with SBP. If there are fewer than 250 cells per millimeter cubed acidic fluid polymorphonuclear cells, empiric antibiotic therapy can be initiated if other signs of infection are present. Up to 86% of acidic fluid culture results may be negative if one dose of an antibiotic is given before cultures are obtained. C. Predictors of poor outcomes include bilirubin greater than 8 mg per deciliter, albumin less than 2.5 grams per deciliter, creatinine greater than 2.1 mg per deciliter, hepatic encephalopathy, hepatorenal syndrome, and upper GI bleeding. D. Administer antibiotic therapy plus albumin if patient meets criteria for use, see below. 1. Empiric therapy targeting enteric gram-negative organisms should be instituted. 2. Third-generation cephalosporins have been studied the most and are considered first-line. They include cefotaxime 2 grams every 8 to 12 hours and ceftriaxone 2 grams per day intravenously. 3. Other agents, such as fluoroquinolones, can be used. Ofloxacin 400 mg orally twice daily can be considered in patients without prior exposure to fluoroquinolones and no evidence of shock, vomiting, grade 2 or higher encephalopathy, or serum creatinine greater than 3 mg per deciliter. 4. Avoid aminoglycosides because of the high risk of renal failure in patients with cirrhosis and SBP. 5. The treatment duration is 5 to 10 days. Most studies suggest that 5-day treatment is as effective as 10 days. We will now discuss the use of albumin. 1. The rationale is that the hemodynamics of patients with cirrhosis reflect a state of intravascular hypovolemia and organ hypoperfusion. SBP is thought to exacerbate this effect, resulting in progressive renal hypoperfusion and precipitation of renal failure or hepatorenal syndrome. 2. The regimen most commonly used is based on one study as published in the New England Journal of Medicine in 1999. A. The albumin dosing is 1.5 grams per kilogram on admission, and 1 gram per kilogram on hospital day 3. B. In addition, give antibiotic treatment. Cefotaxime was used in this study. C. The incidence of renal failure was 10% versus 33% for placebo, with a p-value equal to 0.002. D. In-hospital mortality was 10% for albumin, 29% for placebo with a p-value equal to 0.01. 30-day mortality was 21% with albumin versus 41% for placebo with a p-value equal to 0.03. Guidelines suggest using this albumin regimen with antibiotics if serum creatinine is greater than 1 mg per deciliter, BUN is greater than 30 mg per deciliter, or total bilirubin is greater than 4 mg per deciliter. 5. Regarding the prevention of SBP, A. Prophylactic oral antibiotics are used to reduce the number of enteric organisms in the GI tract, that is GI decontamination, with the hope of reducing the chance of bacterial translocation to prevent SBP in high-risk patients. B. Antibiotic regimens are similar for both primary and secondary prevention. 1. Fluoroquinolones such as ciprofloxacin or norfloxacin are used. 2. We can also use trimethoprim, sulfamethoxazole 1 double-strength tablet for 5 consecutive days per week. C. Regarding primary prevention of SBP, 1. During acute upper GI bleeding, give 7-day course of ceftriaxone during hospitalization. 2. We can also consider indefinite antibiotic prophylaxis in patients without GI bleeding if acidic fluid protein concentration is less than 1.5 grams per deciliter and at least one of the following is present. Serum creatinine is greater than 1.2 mg per deciliter, BUN is greater than 25 mg per deciliter, sodium is less than 130 mg per deciliter, or Child-Turcotte Q score is greater than 9 with bilirubin is greater than 3 mg per deciliter. 3. Use norfloxacin 400 mg once daily or trimethoprim, sulfamethoxazole. D. Regarding secondary prevention, 1. All patients recovering from an initial episode of SBP should be treated with oral prophylactic antibiotics indefinitely. 2. Consider patient for liver transplantation because 2-year survival is 25% to 30% after recovery. F. Regarding hepatorenal syndrome, 1. Criteria in patients with cirrhosis and ascites include serum creatinine greater than 1.5 mg per deciliter, no improvement in serum creatinine to less than 1.5 mg per deciliter after withdrawal of diuretics and administration of albumin, absence of shock, no current nephrotoxins, absence of parenchymal kidney disease and microhematuria, and a normal renal ultrasound. 2. Regarding the subtypes of hepatorenal syndrome, A. In type there is a doubling of serum creatinine to greater than 2.5 mg per deciliter or a 50% reduction in creatinine clearance to less than 20 ml per minute per 1.73 meters squared in less than 2 weeks. B. Type 2 there is non-rapid progression of worsening of renal function. It is associated with high mortality. 3. Regarding the treatment of hepatorenal syndrome, albumin in combination with octreotide dosed at 200 micrograms subcutaneously 3 times daily, or midodrine dosed at 12.5 mg 3 times daily maximum, may be considered for type 1 hepatorenal syndrome. Albumin plus norepinephrine can also be tried if the patient is in the intensive care unit. G. Regarding alcoholic liver disease, 1. It is a subset of chronic liver disease. Patients may develop steatosis and eventually progress to cirrhosis. About 10% to 35% of patients may develop severe alcoholic hepatitis. 2. The prognosis of alcoholic hepatitis may be initially evaluated by the Maddrey discriminant function, abbreviated as MDF, score, calculated as 4.6 multiplied by patient's PT minus control PT plus total bilirubin, measured in mg per deciliter, where PT is prothrombin time. Patients whose score is greater than 32 are believed to have a poor prognosis. Patients with a MELD score greater than 18 can also be considered for drug therapy. A. Patients with an MDF greater than 32, with or without encephalopathy, or a MELD score greater than 18 should be considered for a 4-week course of prednisolone 40 mg per day, followed by a 2-week taper. This may lead to a 30% decrease in the risk ratio of short-term death. B. Patients with an MDF greater than 32 can be considered for treatment with pentoxifylline 400 mg 3 times daily, especially if there are contraindications to corticosteroids. This has been shown to lower hospital mortality by 14% compared with placebo. C. In a recent trial of 1053 patients randomized to receive pentoxifylline, prednisolone, pentoxifylline plus prednisolone, or placebo, none of the treatments resulted in significant mortality reduction as published in the New England Journal of Medicine in 2015. 3. Long-term treatment of alcoholic liver disease with propylthiouracil or colchicine is not recommended. We will now shift gears to viral hepatitis. A. Definitions. For all hepatitis virus infections, acute hepatitis is defined as infection for less than 6 months, whereas chronic infection is infection for more than 6 months. B. We will begin with hepatitis A virus, abbreviated as HAV1. Regarding its background, A. It is an RNA virus that is associated with the development of self-limited hepatitis. B. Its transmission occurs mainly through the fecal-oral route. 1. It is common in areas of poor sanitation. Flooding can lead to increased spread. 2. It can also be foodborne through consumption of shellfish, water, milk, and vegetables. 3. Person-to-person contact, which may be sexual, at daycare centers, via intravenous drug use, in households, and through restaurant workers. C. After exposure, incubation for 14 to 50 days occurs. Patients may have general, nonspecific symptoms such as nausea, vomiting, diarrhea, myalgia, fever, abdominal pain, and jaundice. D. Most patients have self-limited disease lasting less than 2 months. The death of the hepatocyte results in elimination of the virus. HAV is associated with very low mortality, less than 1%, and is not associated with the development of chronic hepatitis. Fulminant hepatitis can occur in some instances. 2. We will now discuss its diagnosis. A. Clinical signs and symptoms include nausea, abdominal pain, jaundice, fever, malaise, or anorexia. Some patients may have mild asymptomatic disease. B. Recent possible exposures. C. Let's move on to laboratory data. 1. IgM antibody to HAV, anti-HAV, is detectable in the serum 5 to 10 days before the onset of symptoms. Once the infection clears, the IgM antibody is replaced by IgG antibodies during a 2 to 6 month period. These antibodies confer lifelong protective immunity against subsequent infection. 2. There is an elevation of aminotransferases. D. The management of acute HAV infection is mainly supportive. Avoid hepatotoxic medications, such as acetaminophen. 3. We will now look at its pre-exposure prophylaxis. A. Active, that is via vaccination, or passive, that is via immune globulin prophylaxis can be used. B. Havrix from GlaxoSmithKline and Vactor from Merck are the two available HAV vaccines. Twinrix is a combination HAV and HBV product from GlaxoSmithKline. C. Populations requiring pre-exposure prophylaxis with HAV vaccine include the following. 1. All children older than 1 year. 2. Children living in areas where rates of hepatitis are above twice the national average. 3. People working in or traveling to countries with high or intermediate endemicity may take up to 4 weeks for full protection. 4. Men who have sex with men. 5. Illicit drug users. 6. Those with occupational risk of exposure, e.g. exposure to sewage. 7. Patients with chronic liver disease. 8. Patients with clotting factor disorders. 9. It is optional among food handlers, and workers in institutions. D. Populations requiring pre-exposure prophylaxis with HAV immune globulin include the following. 1. Travelers to endemic countries. 2. Children younger than 1 year. The vaccine is not approved for this age group. 3. It is dosed at 0.02 ml per kilogram intramuscularly, which offers 3 months coverage or more. 0.06 ml per kilogram intramuscularly, which offers 3 to 5 months coverage. We should repeat every 5 months if travel or exposure is prolonged. 4. Regarding post-exposure prophylaxis, A. Immune globulin can be given at a dose of 0.02 ml per kilogram intramuscularly within 2 weeks of exposure. HAV vaccine can also be used. Efficacy approaches that of immune globulin, but it is recommended only in patients who are 12 months to 40 years old. B. Offer to those not previously vaccinated in the following situations. 1. Close personal contact with a documented infected person. 2. Staff or attendees of daycare centers if one or more cases are recognized in children or employees, or if cases are recognized in 2 or more households of attendees. 3. Let's now consider the common sources of exposures. A. If a food handler receives a diagnosis of HAV, vaccine or immune globulin should be administered to other food handlers at the same establishment. Administration of HAV vaccine or immune globulin to patrons typically is not indicated, but may be considered if 1. The food handler was probably infectious, and he or she both directly handled uncooked or cooked food and had diarrhea or poor hygienic practices. 2 patrons can be identified and treated in 2 weeks or less after exposure. B. In settings where repeated exposures to HAV might have occurred, stronger consideration of HAV vaccine or immune globulin use could be warranted. In a common source outbreak, post-exposure prophylaxis should not be provided to exposed individuals after cases have begun to occur, because the 2-week period after exposure during which immune globulin or HAV vaccine is known to be effective will have been exceeded. C. We will move on to HBV1. As a background, HBV is a DNA virus. There are more than 350 million infected patients worldwide. B. The transmission routes of HBV include 1. Parenteral, among intravenous drug abusers, via needlestick injury, transfusion, ear or body piercing. 2. Bodily fluids like saliva, semen, and vaginal fluid. 3. Sexual contact among heterosexuals and homosexuals. 4. Perinatal, involving mother to child at birth. C. It is associated with both acute and chronic disease. The natural history of HBV is age-dependent. Risk of developing chronic infection after an acute infection is 90% in neonates, 25% to 30% in children younger than 5 years, and 10% in adults. D. Chronic infection with HBV increases the risk of hepatocellular carcinoma. E. Regarding its diagnosis, 1. Its clinical signs and symptoms include nausea, vomiting, diarrhea, myalgia, fever, abdominal pain, and jaundice. 30% may have no symptoms. 2. Regarding its serologic diagnosis, see Table 17. 3. Combinations of serologic markers must be reviewed to distinguish acute from chronic infections. 4. 8 different HBV genotypes A to H exist. Routine genotype testing is not endorsed by the guidelines. Pause the video and carefully scrutinize Table 17 summarizing HBV serologies. A. Most patients have hepatitis B early antigen HBeAg positive disease. B. HBeAg negative disease, mutation in the pre-core or core promoter regions. These variants are known as pre-core mutants. These mutations do not allow monitoring of loss of E antigen as a clinical marker of suppressed replication. Monitor reduction in HBV DNA. Patients infected with these variants also tend to have lower serum HBV DNA and fluctuating liver function tests. C. Centers for Disease Control and Prevention guidelines for screening for HBV infection indicate that the serologic assay for HBV surface antigen (HBsAg) should be the serologic screening test used for the following populations. Additional HBV tests are needed in combination with the HBsAg, for select populations as listed below. 1. People born in geographic regions with HBsAg prevalence greater than 2% regardless of vaccination history. 2. Men who have sex with men also test for anti-HBC or anti-HBs. 3. Past or current intravenous drug users also test for anti-HBC or anti-HBs. 4. Patients receiving cytotoxic chemotherapy or immunosuppressive therapy related to organ transplantation or rheumatologic or GI disorders. In addition, test for anti-HBC or anti-HBs. 5. U.S.-born people not vaccinated as infants whose parents were born in regions with HBV endemicity greater than 8%. 6. People with elevated ALT and AST of unknown etiology. 7. Donors of blood, plasma, organs, tissues, or semen. In addition, test for anti-HBC and HBV DNA. 8. Pregnant women, during each pregnancy, preferably in the first trimester. 9. Infants born to HBsAg-positive mothers. 10. Household, needle sharing, or sex contacts of people known to be HBsAg-positive. In addition, test for anti-HBC or anti-HBs. 11. People who are the sources of blood or bodily fluid for exposures that might require post-exposure prophylaxis. 12. People who are HIV positive. In addition, test for anti-HBC or anti-HBs. 5. Regarding clinical definitions, see Table 18. Pause the video and carefully scrutinize Table 18 summarizing the clinical definitions of HBV. 2. We will now look at the treatment of chronic infection. A. The treatment recommendations include 1. Patients who are HBeAg positive with elevated ALT concentrations and compensated liver disease should be observed for 3 to 6 months for spontaneous conversion from HBeAg positive to anti-HBe or HBeAg positive, indicating seroconversion, before initiating treatment. Antiviral treatment should be considered in patients whose ALT remains greater than 2-fold the upper limit of normal ULN and whose HBV-DNA is greater than 20,000 international units per milliliter. 2. Patients who are HBeAg negative with positive anti-HBe, normal ALT, and HBV is less than 2,000 international units per milliliter should be monitored every 3 months for 1 year and then every 6 to 12 months if they remain in the inactive carrier state. B. Patients who meet the criteria for chronic infection should be treated. Choice of initial therapy is based on patient profile, prior treatments, contraindications to drug therapy, and medication and monitoring costs. C. Monitoring for efficacy should be based on the following responses. 1. Biochemical reduction of liver function tests to within the normal range. 2. Virologic reduction of HBV-DNA to undetectable concentrations and loss of HBeAg if HBeAg positive. A primary non-response is considered a decrease in HBV-DNA of less than 2 log per milliliter after at least 24 weeks of therapy. Patients who do not meet these criteria should receive an alternative treatment. B. Response should be assessed by reductions in HBV-DNA for HBeAg negative patients. 3. We will now discuss drug therapies. A. Regarding pegylated interferon 1. It is a cytokine with antiviral, antiproliferative, and immunomodulatory effects. 2. The best predictors of response to treatment are high pretreatment ALT, low serum HBV-DNA, presence of active inflammation on biopsy, and acquisition of infection. Adult HBeAg negative disease responds less favorably to interferon. 3. Regarding its dosing, A. Pegylated interferon is recommended over interferon alpha because of its reduced dosing frequency and improved tolerance. B. Pegylated alpha-2A, marketed as Pegasus, is dosed at 180 mg subcutaneously once weekly for 48 weeks. The duration is the same for HBeAg negative and HBeAg positive disease. 4. If a response is obtained, it is usually long-lasting, that is more than 4 years. 5. Treatment with interferon typically results in an increase in ALT 4 to 8 weeks into treatment. This response is expected, it should not be viewed as an adverse effect of therapy. 6. Regarding its adverse effects, A. Interferon is associated with many serious adverse effects, including bone marrow suppression. 1. In case of leukopenia, we may use fulgrastim, a granulocyte colony stimulating factor, for support. 2. Thrombocytopenia. There is minimal data with oprelvecin, interleukin 11. It is not used because of many adverse effects including pulmonary hypertension. B. There is predisposition to infections. C. CNS adverse effects include depression, psychosis, anxiety, insomnia, and seizures. Adverse CNS effects occur in 22% to 31% of patients. D. Flu-like symptoms can occur though tolerance usually develops after a few weeks. E. Anorexia, alopecia, thyroid dysfunction, and neuropathy. F. Exacerbation of underlying autoimmune disorders, i.e., thyroid. G. Ischemic or hemorrhagic cerebrovascular disorders. H. Serious hypersensitivity and rash formation. I. Manufacturers give recommendations for dose reductions in patients who develop bone marrow suppression and depression while on therapy. J. It is contraindicated in patients with current psychosis, a history of severe depression, neutropenia, thrombocytopenia, symptomatic heart disease, decompensated liver disease, and uncontrolled seizures. Also use caution in patients with autoimmune disorders. B. We will now look at reverse transcriptase inhibitors. 1. In general, lamivudine and tolbuvudine are not preferred as first-line therapies because of high rates of resistance. 2. All reverse transcriptase inhibitors carry a black box warning for the development of lactic acidosis and severe hepatomegaly with steatosis. Monitor for worsening liver function tests, and periodically assess renal function. Female and obese patients are at higher risk. Reductions in bone mineral density, abbreviated as BMD, have been associated with long-term use. Assess baseline BMD in patients older than 12 years with a history of pathologic fracture or osteoporosis. 3. Tenofovir and entecavir are preferred antivirals in HBV with decompensated cirrhosis, where they are safer than pegylated interferon and have higher potency and minimal risk of resistance compared with other antivirals. 4. We will now discuss entecavir, marketed as baricilude. A. It is indicated for HBeAg negative and HBeAg positive patients with persistently elevated AST or ALT or histologically active disease. It is effective in lamivudine-resistant YMDD mutants. B. It reduces HBV DNA by up to 6.86 log in HBeAg positive, naive patients and by 5.2 log in HBeAg negative patients or those with lamivudine resistance. C. It is dosed at 0.5 mg orally once daily for patients older than 16 years and nucleoside naive and 1 mg orally once daily for patients older than 16 years with HBV viremia while receiving lamivudine or in lamivudine-resistant HBV. D. Dose adjustments are required for renal impairment. E. Its toxicity is similar to lamivudine with headache, cough, upper respiratory infection, and abdominal pain, with possibly fewer ALT flares. Rare lactic acidosis is reported. Resistance to entecavir is reported as similar to 1% at 5 years. 5. We will now discuss tenofovir, marketed as Viread 300 mg, or Vemlidy 25 mg. A. It is a nucleotide analog, formulated as tenofovir disoproxyl fumarate, marketed as Viread, or tenofovir alafenamide, marketed as Vemlidy, indicated for chronic HBV infection. B. It is effective for lamivudine-resistant HBV. C. Dose adjustments for tenofovir are required for renal impairment. D. Regarding its toxicity, it is overall well tolerated. Headache, nausea, and nasopharyngitis are most commonly reported. It has potential renal toxicity, so periodic monitoring of serum creatinine is recommended. Potential ALT flares occur on withdrawal. It rarely causes lactic acidosis. Tenofovir alafenamide is associated with less renal and bone toxicity. 6. HBV treatment is summarized in Table 19. Pause the video and carefully scrutinize Table 19 summarizing the treatment recommendations for chronic HBV infection in adults. 4. We will now shift gears to preventive strategies. A. Vaccination pre-exposure is indicated in the following groups. 1. All infants. 2. Unvaccinated children younger than 19 years. 3. Individuals at risk of infection by sexual exposure, e.g. sex partners of HBsAg-positive individuals, sexually active individuals not in a long-term, mutually monogamous relationship, individuals seeking evaluation or treatment for a sexually transmitted infection, and men who have sex with men. 4. Individuals at risk of infection by percutaneous or mucosal exposure to blood, that is current or recent injection drug users, household contacts of HBsAg-positive individuals, residents and staff of facilities for developmentally disabled persons, healthcare and public safety personnel with a reasonably anticipated risk of exposure to blood or blood-contaminated body fluids, hemodialysis patients and pre-dialysis, peritoneal dialysis, and home dialysis patients, individuals with diabetes 19 to 59 years of age, individuals with diabetes 60 years and older at the discretion of the treating clinician. 5. Others, international travelers to countries with high or intermediate levels of endemic HBV infection, HBsAg prevalence of 2% or greater, individuals with hepatitis C virus infection, individuals with chronic liver disease, individuals with HIV infection, incarcerated individuals, all other individuals seeking protection from HBV infection. B. We will now look at available HBV vaccines whose dose schedules vary by age. 1. Their dose schedules are summarized in Table 20. 2. Obtain titers 1 to 2 months after the third dose of the series for HCPs. 3. HBV vaccines are available as combination products with HAV, e.g. Twinrix, DTP and IPV, e.g. Pediarix, and HIB, e.g. Comvax. Pause the video and carefully scrutinize Table 20 summarizing dose schedules for hepatitis B vaccinations. C. We will now discuss post-exposure prophylaxis. 1. Exposure can result in the need for HBV vaccine or immune globulin. 2. Doses of HBV immune globulin are 0.06 ml per kilogram intramuscularly and must be given within 7 days of exposure. 3. Patient populations requiring post-exposure prophylaxis include a. Cases of perinatal transmission. 1. Involving children born to HBsAg-positive mothers should receive the first dose of the 3-dose vaccine series plus HBV immune globulin within 12 hours of birth. 2. Children born to mothers with unknown HBsAg status but suspected should receive the first dose of the 3-dose vaccine series within 12 hours of birth. Testing should be performed on the child, and if positive, HBV immune globulin should be administered within 1 week. 3. Infants weighing less than 2 kilograms at birth whose mothers are documented as HBsAg negative should receive the first dose of the vaccine series 1 month after birth or at hospital discharge, whichever comes first. B. Sexual contact or household contact with an infected person. They should receive HBV immune globulin plus vaccine series if exposed person is previously unvaccinated. C. Sexual contact or household contact with an HBV carrier. They should receive vaccine series if exposed person was previously unvaccinated. D. Post-exposure recommendations for HCPs are summarized in Table 21. Pause the video and carefully scrutinize Table 21 summarizing the Centers for Disease Control and Prevention recommendations for management of HBV post-exposure for HCPs. D. We will now switch gears to HCV1. Background A. It is an RNA virus with 6 genotypes and 50 subtypes. 1. Genotype 1 has subtypes 1A, 1B, and 1C, and accounts for 70% to 75% of infections in the United States. 2. Genotype 2 has subtypes 2A, 2B, and 2C, and genotype 3 has subtypes 3A and 3B, are less common in the United States. 3. The genotype helps determine therapy duration and likelihood of responding to therapy. B. It is the leading cause of liver disease and liver transplantation in the United States. It is also a common cause of hepatocellular carcinoma. C. Viral replication occurs in the hepatocyte. The virus is not directly cytopathic. D. Transmission is mainly bloodborne via transfusion or intravenous drug abuse. 1. There is a high risk of transmission in the following: A. Blood transfusion. B. Intravenous drug abuse. C. Men who have unprotected sex with men. D. Hemodialysis. E. Incarceration. 2. There is a low risk of transmission in the following cases: A. Snorting cocaine or other drugs. B. Occupational exposure. C. Body piercing and acupuncture with unsterilized needle. D. Tattooing. E. From pregnant mother to child. F. Non-sexual household contacts, which is rare. G. Sharing razors or toothbrushes. H. Sexual transmission. E. It is associated with acute and chronic infection. After acute infection, most patients, that is 60% to 85%, develop chronic infection. 2. We will now look at its clinical features. About 30% of patients are asymptomatic. A. Regarding acute infection, symptoms present 4 to 12 weeks after exposure. Most patients are asymptomatic and seldom progress to fulminant disease. Those who develop symptoms have nonspecific findings such as malaise, weakness, anorexia, and jaundice. B. Chronic infection is defined as the presence of viral RNA in the serum for 6 months or more. 1. It may be associated with the long-term development of end-stage liver disease, cirrhosis, hepatocellular carcinoma. 2. Progression to complications and end-stage liver disease can be accelerated by concurrent alcohol use and co-infection with HIV. Younger female patients have slower progression. C. Extrahepatic manifestations include rheumatoid symptoms, glomerulonephritis, and cryoglobulinemia. 3. We will now discuss its diagnosis and monitoring. A. Clinical signs and symptoms include nausea, abdominal pain, jaundice, fever, malaise, or anorexia. Many patients have asymptomatic disease. B. Populations to test include 1. Individuals with suspected exposure. 2. Individuals with HIV infection. 3. Intravenous or intranasal drug abusers. 4. Recipients of clotting factors before 1987 or blood before 1992. 5. Patients undergoing hemodialysis. 6. Patients with abnormal ALT. 7. Those receiving an organ transplant before 1992, including those who were ever incarcerated. 8. Adults born between 1945 and 1965. 9. Individuals getting a tattoo in an unregulated setting. 10. Healthcare, emergency medical, and public safety workers after needle sticks, sharps, or mucosal exposures to HCV-infected blood. 11. Unexplained chronic liver disease and chronic hepatitis, including elevated ALT. 12. Annual testing for injection drug users and HIV-positive men who have unprotected sex with men. C. Important laboratory values include 1. Serum anti-HCV antibodies. It has 99% sensitivity and specificity. Enzyme immunoassays are used as an initial screening for HCV. The presence of anti-HCV antibody does not confer protective immunity from subsequent infection. A. If serum anti-HCV antibodies are positive, confirmatory testing by a sensitive HCV RNA test is warranted. B. Quantitative HCV RNA testing to document baseline viremia before initiating antiviral therapy. C. If sustained virologic response, abbreviated as SVR, is undetectable HCV RNA 12 weeks after completion of treatment, it is considered a virologic cure. 3. Liver biopsy should be considered if patient and HCP want to obtain information about fibrosis stage or prognosis or to make a decision about treatment. Regarding ALT, it is nonspecific. It may fluctuate with chronic disease. It should decrease with treatment. 4. Regarding genotyping, genotype 1 is the most common genotype in the United States. It is also the least responsive to treatment. Genotypes 2 and 3 are the other two most common genotypes in the United States. 5. Treatment response depends on other factors such as race, age, or co-infection. IL-28B genotyping can also be considered for genotype 1 infection to help predict response to therapy. 4. Regarding its treatment, A. In the case of acute HCV infection, 1. Pre-exposure or post-exposure prophylaxis is not recommended. 2. We should monitor hepatic panel at 2 to 4 week intervals and HCV RNA every 4 to 6 weeks for 6 to 12 months to detect spontaneous clearance. If the decision is to treat, monitor for at least 12 weeks to 16 weeks to detect spontaneous clearance. 3. The same regimens used for chronic HCV are recommended for treatment. B. In the case of chronic infection, 1. Therapy goal is to attain a SVR, defined as the absence of detectable HCV RNA 12 weeks after treatment and is considered a clinical cure if obtained. 2. With the availability of direct-acting antivirals and interferon-sparing therapies, treatment is recommended for all patients with chronic HCV infection, except those with short life expectancies that cannot be altered by treating HCV, transplantation, or other directed therapy. 3. 2 direct antiviral products are no longer recommended for treatment because of adverse effects and drug interactions, Symprevir and Ombitasvir plus Dasubiavir with Paritaprevir plus Ritonavir. C. We will now look at ribavirin in the treatment of HCV infection. 1. It is an oral nucleoside analog. 2. It is available as 200 mg tablets, marketed as Copagas, or capsules marketed as Ribitol. Generics are available. 3. It has a significant adverse effect profile. A. Hemolytic anemia can occur in up to 10% of patients, usually within 1 to 2 weeks of initiating therapy. This may worsen underlying cardiac disease. We should monitor complete blood cell count (CBC) at baseline, 2 weeks, 4 weeks, and periodically thereafter. In patients with no cardiac history, decrease the dose to 600 mg per day when hemoglobin drops to 10 grams per deciliter or less, and discontinue when hemoglobin drops to 8.5 grams per deciliter or less. In patients with a cardiac history, decrease the dose to 600 mg per day if hemoglobin drops more than 2 grams per deciliter in any 4-week period during treatment. Discontinue if hemoglobin drops to less than 12 grams per deciliter 4 weeks after dose reduction. Epoetin or darbepoetin can be used to stimulate red blood cell production, improve anemia, and sustain initial starting dose. It is also necessary to confirm that iron study results are normal and within range during treatment. B. Regarding teratogenicity, it is classified as a Category X drug. It requires a negative pregnancy test at baseline and every month up to 6 months after treatment, as well as the use of 2 forms of barrier contraception during treatment and for 6 months after treatment. This applies to women taking the drug and female partners of male patients taking ribavirin. C. Other possible adverse events include pancreatitis, pulmonary dysfunction, manifesting as dyspnea, pulmonary infiltrate, and pneumonitis, insomnia, irritability or depression, often called riba rage, and pruritus. D. NS5B or A polymerase inhibitors sofosbuvir, marketed as Sovaldi, and sofosbuvir co-formulated with ladipasvir, marketed as Harvoni. 1. Regarding their indications, A. Sofosbuvir is used in treatment of HCV genotypes 1, 2, 3, and 4, including those with hepatocellular carcinoma meeting Milan criteria and those with HCV/HIV co-infections. B. Sofosbuvir co-formulated with ladipasvir is used in treatment of HCV genotype 1, 4, 5, or 6 infection. 2. Dosing is 400 mg tablet once daily with or without food. A. Regarding sofosbuvir renal dosing, there are no dosing recommendations for glomerular filtration rate, GFR, less than 30 ml per minute. B. Dose reductions for ribavirin are recommended in the following cases. 1. When used with sofosbuvir according to U.S. prescribing information, ribavirin 600 mg daily is recommended for patients with no cardiac disease if hemoglobin is less than 10 grams per deciliter, and recommendations are to discontinue if hemoglobin is less than 8.5 grams per deciliter. In patients with stable cardiac disease, reduce the ribavirin dose if there is a greater than 2 grams per deciliter decrease in hemoglobin during any 4-week period, and discontinue if hemoglobin is less than 12 grams per deciliter, despite 4 weeks at reduced dose. 2. When used with sofosbuvir according to the 2016 AASLD Infectious Diseases Society of America (IDSA) guidelines. For GFR 30 to 50 ml per minute, use alternating doses of 200 and 400 mg daily. For GFR less than 30 ml per minute or with end-stage renal disease or hemodialysis, reduce to 200 mg per day. 3. Adverse effects include fatigue and headache. 4. Regarding the drug interactions, A. Avoid use with potent P-glycoprotein, abbreviated as PGP, inducers. B. Their concentrations are significantly affected by anticonvulsants, e.g., carbamazepine, phenytoin, phenobarbital, and oxcarbazepine, rifabutin, rifampin, St. John's wort, and tipranavir co-formulated with ritonavir. C. Avoid using with amiodarone because of symptomatic bradycardia. The mechanism of this interaction is not known. We will now look at NS5A inhibitor daclatasvir, marketed as Daclinza 1. It is indicated for the treatment of genotype 1 or 3 infection in combination with sofosbuvir. SVR rates are reduced in the presence of cirrhosis. 2. It is dosed at 60 mg once daily with or without food. No dosage adjustments are required for renal or hepatic dysfunction. 3. Its adverse effects include headache, fatigue, nausea, and diarrhea. 4. Regarding its drug interactions, A. When administered with strong CYP3A4 inhibitors, e.g., ritonavir, clarithromycin, itraconazole, or ketoconazole, we should reduce its dose to 30 mg daily. B. When administered with moderate CYP3A4 inducers, e.g., bosentan, dexamethasone, efavirenz, and etravirin, we should increase its dose to 90 mg daily. C. It is contraindicated in combination with strong CYP3A4 inducers, e.g., carbamazepine, phenytoin, rifampin, and St. John's wort. F. We will now look at an NS3/4A inhibitor grazoprevir combined with an NS5A inhibitor elbasvir, marketed as Zepotir 1. It is indicated in the treatment of genotypes 1 or 4 infection with or without ribavirin. 2. It is dosed at grazoprevir 100 mg/elbasvir 50 mg fixed-dose combination tablet once daily for 12 or 16 weeks. A. Testing for NS5A resistance-associated substitutions, abbreviated as RASs, is recommended. If RASes are present, the treatment duration should be extended to 16 weeks, and ribavirin should be co-administered. B. Renal dose adjustment is not necessary, including patients receiving hemodialysis. 3. Adverse effects include a. ALT elevations. We should check ALT at baseline, 8 weeks of therapy, and 12 weeks of therapy if 16-week duration is indicated. The product is contraindicated in child Q class B or C. B. Other adverse effects include headache and fatigue. 4. Due to drug interactions, a. It is contraindicated in combination with OATP1B1/3 inhibitors, strong CYP3A inducers, and efavirenz. G. We will now consider NS5A/B inhibitor combination velpatasvir/sofosbuvir, marketed as Epclusa-1. It is indicated in the treatment of genotype 1 to 6 infection. 2. It is dosed at velpatasvir 100 mg/sofosbuvir 400 mg fixed-dose combination tablet once daily for 12 weeks. Weight-based ribavirin is added if decompensated cirrhosis is present with HCV genotypes 1 to 4. 3. Its adverse effects include headache and fatigue. 4. Due to drug interactions, a. It is contraindicated with inducers of PGP and moderate to potent inducers of CYP2B6, CYP2C8, or CYP3A4, e.g., rifampin, St. John's wort, and carbamazepine, which can decrease plasma concentrations of sofosbuvir and/or velpatasvir. B. We should avoid use of amiodarone and sofosbuvir because of symptomatic bradycardia. H. Next we will talk about NS5A/B and NS3/4A inhibitor combination velpatasvir, sofosbuvir, and varxiloprevir, marketed as Vosavir-1. It is indicated in the treatment of a. Genotypes 1 to 6 infection with or without compensated cirrhosis, that is a child Turcotte Q-A, in patients who have been treated with an HCV regimen containing an NS5A inhibitor. B. Genotypes 1A or 3 who have been treated with a sofosbuvir containing regimen without an NS5A inhibitor. 2. It is dosed at sofosbuvir 400 mg with velpatasvir 100 mg with varxiloprevir 100 mg fixed-dose combination tablet once daily with food for 12 weeks. 3. Its adverse effects include headache, fatigue, diarrhea, and nausea. 4. For its drug interactions, see velpatasvir co-formulated with sofosbuvir, marketed as Epclusa listing above. Next we will look at the NS3/4A and NS5A inhibitor combination glecaprevir and pibrentasvir, marketed as Mavirae-1. It is indicated in a. Genotype 1 to 6 infection with or without compensated cirrhosis, with a child Turcotte Q-A. B. Genotype 1 infection in patients who have previously been treated with either an NS5A inhibitor or an NS3/4A inhibitor, but not both. 2. It is dosed at glecaprevir 100 mg plus pibrentasvir 40 mg fixed-dose combination tablet, 3 tablets once daily with food for a. 8 weeks for genotype 1 to 6 treatment-naive patients without cirrhosis. B. 12 weeks for genotype 1 to 6 treatment-naive patients with compensated cirrhosis. C. 8 to 16 weeks for patients previously treated, depending on prior regimen. 3. Its adverse effects include headache, fatigue, and nausea. 4. Due to its drug interactions, we should avoid its use with PGP or CYP3A inducers like carbamazepine, efavirenz, St. John's wort, because this can reduce the concentration of glecaprevir and pibrentasvir. It is contraindicated with atazanavir or rifampin. J. Treatment recommendations for chronic HCV infection are included in Table 22. Pause the video and carefully scrutinize Table 22 summarizing treatment recommendations for chronic HCV infection in treatment-naive patients with or without compensated cirrhosis. 5. We should monitor the following: A. Baseline HCV-RNA, genotype, quantitative HCV-RNA, HCV viral load, CBC, liver function tests, and calculated GFR. Pregnancy test should be done for women receiving ribavirin. We should evaluate for potential drug-drug interactions. B. On therapy, we should monitor medication adherence, potential drug-drug interactions, HCV viral load, CBC, serum creatinine, calculated GFR, LFTs at 4 weeks, then as clinically indicated. C. After treatment, we should check HCV-RNA at 12 weeks to assess for SVR. 6. Regarding prevention of HCV, A. There is no vaccine or immune globulin available. B. Risk factor modification includes 1. Focus on intravenous drug abuse through methadone maintenance and syringe exchange. 2. Focus on sexual contact through appropriate barrier contraception. 3. We should avoid blood exposure by observing or adhering to universal occupational precautions, or avoiding other contact, e.g., sharing toothbrushes or razors or receiving a tattoo. 4. The HAV and HBV vaccines should be administered to prevent further progression of liver disease. We will now switch gears and discuss nausea and vomiting. A. Let's begin with definitions and pathophysiology. 1. Definitions. A. Nausea is an unpleasant sensation of the imminent need to vomit, which may or may not lead to vomiting. B. Vomiting is a forceful expulsion of gastric contents associated with contraction of the abdominal and chest wall musculature. 2. Regarding the pathophysiology. A. Stimuli for nausea are processed through several major anatomic areas, each of which has various receptors associated with input to the medullary vomiting center. 1. Visceral stimuli is mediated through dopamine and serotonin receptors. Its major stimuli include A. Gastric irritants. B. Non-gastric stimuli, peritonitis, intestinal or biliary distension, pancreatitis, and gastroparesis. C. Abdominal radiation. D. Chemotherapeutic agents. E. Pharyngeal stimulation. 2. The chemoreceptor trigger zone located in the area postrema is mediated by dopamine via D2 receptors, serotonin, and some histamine via H1 receptors, and muscarinic via M1 receptors, and substance P, neurokinin 1. The major stimuli include the following: A. Medications, e.g. opiates, dopamine agonists, digoxin, chemotherapeutic agents, macrolides, and general anesthetics. B. Metabolic disturbances, e.g. uremia, diabetic ketoacidosis, hypercalcemia, and hypoxemia. C. Bacterial toxins. D. Radiation therapy. 3. Vestibular labyrinths, mediated through H1 and M1 receptors. Major stimuli include the following: A. Motion sickness. B. Labyrinth infection. 4. Cerebral cortex. Here the receptor involvement is not well characterized. Noxious odors, visions, and tastes cause it. B. Clinical consequences of nausea and vomiting include dehydration, electrolyte disturbances, aspiration, and Mallory-Weiss syndrome. Pause the video and carefully scrutinize Table 23 summarizing common clinical conditions associated with nausea and vomiting. B. We will now discuss treatment and prevention strategies for nausea and vomiting. 1. We should remove or treat the underlying cause. See Table 23. 2. We should correct dehydration and electrolyte disturbances. Oral rehydration is preferred, if possible, with oral rehydration solutions, e.g., Pedialyte, diluted Gatorade. 3. Regarding drug treatment, we should use drugs that target receptors involved with stimuli. May need combination of drugs with different mechanisms. also may need alternative dose forms such as intravenous, subcutaneous, suppository. We will now consider the major drug classes of antiemetics. All of them are antagonists at the respective receptors. See Table 24. B. Drugs of choice for different situations include 1. General medical use, e.g. phenothiazines, and serotonin antagonists. 2. For chemotherapy-induced nausea and vomiting, we use serotonin antagonists, NK1 antagonists, and corticosteroids. See Oncology Supportive Care chapter for treatment and prevention. 3. For postoperative nausea and vomiting, we use serotonin antagonists, and scopolamine. 4. For motion sickness, we use antihistamines, and scopolamine. 5. In pregnancy, we use phosphorylated carbohydrate solution, pyridoxine, and antihistamines. 6. In the case of nausea and vomiting due to gastroparesis, we use metoclopramide. C. Non-drug therapy for nausea and vomiting include acupressure wristbands, C-band, which work by stimulating the pericardium 6p6 point. Pause the video and carefully scrutinize Table 24 summarizing select antiemetics. We will now discuss pancreatitis. We will begin with its classification and pathophysiology. 1. Acute pancreatitis A is characterized by inflammation in the pancreas ranging from mild to severe. B. An initial insult leads to the release of trypsin in the pancreas, leading to the activation of pancreatic enzymes and intrapancreatic inflammation and complications. It can then progress to extrapancreatic complications. It is usually reversible once the underlying cause is addressed. C. It has two distinct phases, namely, 1. Early phase occurring within 1 week, it is associated with systemic inflammatory response syndrome or organ damage. 2. Late phase occurring more than 1 week. It is associated with local complications. D. Typical signs and symptoms include abdominal pain and distension, nausea, vomiting, jaundice, and fever. 1. Local complication, necrosis, hemorrhage, pseudocyst, abscess, infection. 2. Regarding systemic complications, they manifest as systemic inflammatory response syndrome, acute respiratory distress syndrome, shock, and organ failure. The main causes of acute pancreatitis are as follows: 1. Long-term alcohol abuse, 2. Gallstones, and 3. Drugs as shown in Box 5. Pause the video and carefully scrutinize Box 5 summarizing common causes of drug-induced pancreatitis. Other causes of acute pancreatitis include 4. Post-endoscopic retrograde cholangiopancreatography. 5. Hypertriglyceridemia, generally greater than 1000 mg per deciliter. 6. Idiopathic causes. 7. Structural abnormalities. 8. Toxins, e.g. scorpion venom. 9. Trauma. And 10. Ischemia. 2. Chronic pancreatitis A is characterized by irreversible structural and functional loss of pancreatic function caused by long-standing inflammation and repeated injury. B. Repeated injury results in loss of both exocrine and endocrine function. C. Typical signs and symptoms of chronic pancreatitis include chronic abdominal pain, steatorrhea, weight loss or cachexia, jaundice, and hyperglycemia. Complications include diabetes, pseudocysts, calcification, ascites, and biliary stricture. D. Risk factors for chronic pancreatitis are based on the M-ANNHEIM classification. M stands for multiple risk factors, A stands for alcohol consumption, N stands for nicotine, N stands for nutritional factors, high fat and protein, hyperlipidemia, H stands for hereditary factors, E stands for efferent duct factors, I stands for immunologic factors, M stands for miscellaneous and rare factors, which includes drugs. B. Regarding its diagnosis. 1. In the case of acute pancreatitis, A. Diagnosis is typically based on two of the three following criteria: 1. Presence of abdominal pain. 2. Laboratory diagnosis, basing on a serum lipase greater than 3 times the upper limit of normal, which is the most sensitive test. Patients may also have hyperglycemia and other electrolyte abnormalities related to vomiting. Patients often have a leukocytosis and a fever. 3. Imaging. Abdominal ultrasonography and computed tomography (CT) scan to evaluate pancreas, biliary system, and presence of local complications. B. Severity and prognosis as shown in Table 25. Pause the video and carefully scrutinize Table 25 summarizing common scoring systems to classify severity and prognosis of acute pancreatitis. 2. The diagnosis of chronic pancreatitis is typically based on the clinical signs and symptoms plus laboratory and imaging. A. Regarding laboratory diagnosis, serum lipase may be normal, hyperglycemia and low albumin or prealbumin may also be present. B. Imaging. The CT scan may reveal pancreatic calcification or pseudocyst. C. We will briefly look at the treatment strategies. 1. In the case of acute pancreatitis, treatment is largely supportive. It should include removal or treatment of underlying cause if possible. A. We should temporarily withhold oral intake and provide rehydration with intravenous fluids, typically 250 to 500 ml per hour of lactated Ringer solution. Treat electrolyte disturbances such as hyperkalemia, hypercalcemia, and hyperglycemia. B. Pain management involves the use of intravenous narcotics. We should avoid meperidine. Patient-controlled analgesia is often used. C. Regarding antiemetics, intravenous ondansetron, prochlorperazine, or promethazine are used. D. Regarding nutrition, if pancreatitis is mild, then oral feeding can be resumed if no vomiting is present. If severe pancreatitis is present, use enteral nutrition to prevent infectious complications. Avoid total parenteral nutrition due to higher rates of infection, mortality, and length of stay. E. Antibiotics, in general, are not recommended for routine prophylaxis in severe pancreatitis. Antibiotics can be used if extrapancreatic infection is present. If infected necrosis is present, then carbapenems, fluoroquinolones, or metronidazole may be useful in delaying the need for intervention. F. Endoscopic retrograde cholangiopancreatography may be needed for cholangitis or gallstone pancreatitis. This is often followed by cholecystectomy to prevent future episodes. 2. Regarding chronic pancreatitis, treatment is largely symptomatic. A. Abstinence from alcohol is essential. Pharmacologic intervention and supportive care, e.g., Alcoholics Anonymous, may be needed. B. Pain management often requires a combination of non-narcotic and narcotic analgesics such as long-acting morphine, oxycodone, or transdermal fentanyl, in combination with pancreatic enzyme replacement. Avoid acetaminophen if long-term alcohol use is a factor. C. Regarding antiemetics, oral ondansetron, prochlorperazine, or promethazine are administered as needed. D. Regarding nutrition, the goal is to maximize caloric intake and weight gain and reduce steatorrhea. We may need more frequent, lower-fat meals and fat-soluble vitamin supplementation. Long-term enteral or parenteral nutrition may be required. E. We will now discuss the use of pancreatic enzyme replacement therapy. 3. Pancreatic enzyme replacement therapy. A. Simulate the digestion of food that normally occurs with normal pancreatic enzyme release to reduce maldigestion and malabsorption. B. Products are enteric-coated microspheres or microtablets that contain lipase, amylase, and protease. Meant to mix with food, they release enzymes at intestinal pH values greater than 5.5. Products should not be crushed or chewed. C. Enzyme products were historically considered nutritional supplements. The FDA has now mandated FDA approval of all enzyme products. See Table 26. Pause the video and carefully scrutinize Table 26 summarizing selected pancreatic enzyme replacement products. D. Dosing is based on the lipase content, expressed in units, of the product. 1. The starting adult doses are generally 30,000 to 40,000 units per meal, with a half dose for snacks. May also use weight-based dosing of 500 to 1,000 units per kilogram per meal for those older than 4 years or 1,000 to 2,500 units per kilogram per meal for ages 1 to 4. 2. The maximum dose is 2,500 units per kilogram per dose or 10,000 units per kilogram per day. 3. Give enzymes immediately before or during a meal. 4. Titrate according to weight gain and reduction in steatorrhea. 5. May need to add PPI if maximal response is not seen. Adverse effects of pancreatic enzyme therapy. 1. Nausea or abdominal cramping. 2. Enzymes are derived from porcine pancreas. This is contraindicated if a pork allergy is present. 3. Hyperuricosuria and hyperuricemia. 4. Fibrosing colonopathy, generally seen with doses greater than 10,000 units per kilogram per day. 5. These products are pregnancy category C. We will now progress to diarrhea. Let's begin with its classification and pathophysiology. 1. Regarding the clinical definition, it is the alteration in a normal bowel movement characterized by an increase in the water content, volume, or frequency, that is more than 3 per day of stool. Acute diarrhea is generally considered to last less than 72 hours to 14 days. B. Chronic diarrhea is generally considered to last more than 14 to 30 days. 2. Diarrhea can be classified into several major categories related to the underlying cause. Secretory diarrhea 1. Is secondary to enhanced secretion by intestinal mucosa. Often, large, watery volume with loss of electrolytes. 2. Its common causes include bacterial or viral or bacterial enteritis, gastric hypersecretion, carcinoid, stimulant laxatives, bile acid malabsorption, celiac disease, and IBD which is mucosal. B. Osmotic diarrhea 1. Is secondary to a hyperosmolar gradient in the intestinal lumen. 2. Its common causes are osmotic laxatives, carbohydrate malabsorption due to lactase deficiency, fat malabsorption due to pancreatic insufficiency, and short bowel syndrome. C. Exudative or inflammatory diarrhea 1. Is secondary to inflammation or infiltration or invasion of the intestinal mucosa. 2. Its common causes include IBD, invasive infection due to Clostridioides difficile toxin, enterotoxigenic Escherichia coli, cytomegalovirus, and Shigella species, ischemic colitis, radiation enterocolitis, neoplasm. D. Altered motility or motor function-based diarrhea 1. Secondary to autonomic nerve dysfunction. 2. Common causes include diabetic neuropathy, postvagotomy, hyperthyroidism (IBS), and Addison disease. 3. Drug-induced diarrhea can occur by a variety of mechanisms. See Box 6 for a list of medications that commonly cause diarrhea. Pause the video and carefully scrutinize Box 6 summarizing common causes of drug-induced diarrhea. B. Regarding its diagnosis 1. We should conduct a thorough patient history. We should evaluate for disease and drug-induced causes, e.g., laxative, or recent antibiotic use, recent travel history, and temporal relation to food intake. B. Assess fluid and electrolyte status. C. Assess CBC and stool culture, and evaluate for ova and parasites if infectious cause is suspected. Assess for Clostridioides difficile toxin and culture if there has been recent antibiotic use or hospitalization. D. Evaluate stool pH, electrolytes, osmolarity, or fat content, if indicated. E. Imaging using abdominal CT scan or endoscopy with biopsy may be indicated, particularly for inflammatory diarrhea or suggestion of neoplasm or celiac disease. 2. Referral to higher level of care or further evaluation may be necessary for some patients. A. Immunocompromised. B. Infants and children. C. Pregnant women. D. Presence of fever. E. Blood in the stool. F. Weight loss greater than 5%. G. Suspected invasive infection. C. Regarding the treatment strategies, 1. It entails removal or treatment of underlying causes, if possible. 2. Rehydration. A. Intravenous fluids is appropriate for hospitalized patients. B. Oral rehydration is appropriate for all patients if no vomiting is present. 1. Sodium and glucose are key ingredients of oral rehydration solutions, because they have active uptake into the intestinal mucosa even during active diarrhea. This results in water being pulled back into circulation. Other formulations, popsicles, are also available. 2. Gatorade may need to be diluted because it has a large amount of carbohydrates. 3. Dietary modifications. A. Avoid dairy products because transient lactase deficiency can occur. B. Brat diet for adults. Mild foods such as bananas, rice, applesauce, toast. C. May need to interrupt feedings for pediatric patients. 4. Drug therapy for diarrhea is listed in Table 27. See Infectious Diseases chapter for management of infectious causes. Pause the video and carefully scrutinize Table 27 summarizing select therapies for the management of diarrhea. Let's now shift gears to constipation. A. We will first of all consider its definition and pathophysiology. 1. Bowel symptoms, e.g., difficult or infrequent passage of stool, hardness of stool, or a feeling of incomplete evacuation, may occur in isolation or secondary to another underlying disorder. The 2013 guidelines distinguish between normal transit constipation and slow transit constipation. Another definition is a symptom-based disorder defined as unsatisfactory defecation and is characterized by infrequent stools, difficult stool passage, or both. As published in the American Journal of Gastroenterology in 2014. It may also be characterized by difficulty with or incomplete evacuation, straining, or presence of hard, dry stools. Abdominal pain and distension can occur, as well as low back pain and anorexia. 3. Pathophysiology is related to many different factors. Common causes include a. Altered motility, e.g., ileus. B. Neurogenic causes, autonomic neuropathies, and Parkinson disease. C. Endocrine or metabolic disorders, e.g., hypothyroidism, diabetes, hyperkalemia, hypercalcemia, and uremia. D. Pregnancy. E. Psychogenic causes. F. Structural abnormalities or obstruction. G. Nutritional causes, e.g., reduced fiber and water intake. H. Medications as shown in Box 7. 4. Constipation that is not caused by an underlying organic cause is called chronic idiopathic constipation, abbreviated as CIC, or functional constipation. Pause the video and carefully scrutinize Box 7 summarizing common causes of drug-induced constipation. B. Regarding the diagnosis of constipation. 1. We need to evaluate patient history thoroughly. A. We need to establish patient baseline and evaluate for disease and drug-induced causes. B. Assessment of fluid and electrolyte status, and thyroid function should be done. C. Imaging using an abdominal CT scan or radiograph may be necessary to assess for ileus, obstruction, or dilatation. 2. Referral for further evaluation may be necessary for some patient populations. A. Symptoms for more than 1 to 2 weeks despite treatment. B. Considerable pain or cramping. C. Pregnancy. D. Presence of fever. E. Blood in the stool. F. Reduction in stool caliber. G. Weight loss. H. Paraplegia and quadriplegia. 3. We will now discuss the diagnosis of CIC, functional constipation. It is based on the Rome 4 criteria, which is presence of two or more of the following: A. Straining during at least 25% of defecations. B. Lumpy or hard stools in at least 25% of defecations. C. Sensation of incomplete evacuation for at least 25% of defecations. D. Sensation of anorectal obstruction or blockage for at least 25% of defecations. E. Manual maneuvers to facilitate at least 25% of defecations, e.g., digital evacuation, support of the pelvic floor. F. Fewer than 3 defecations per week. C. Let's now discuss treatment strategies used in the management of constipation. 1. We should remove or treat underlying causes, if possible. 2. Regarding non-pharmacologic interventions, A. We should increase fluid intake to 6 to 8 glasses of water per day, although minimal evidence to support efficacy if dehydration is not present. B. We should increase dietary fiber to 20 to 30 grams per day. C. Incorporate or increase exercise to 3 to 5 days per week. D. Regarding modifying behaviors, we should do toilet training and toileting position. 3. Regarding drug therapy for prevention and treatment of constipation, see Table 28. A. Choose drug therapy on the basis of desired onset of action, patient preference, presence of potential contraindications, and use in special populations. B. Provide patient education on alternative dose forms, enema, suppository. Pause the video and carefully scrutinize Table 28 summarizing drug therapy options for treatment and prevention of constipation. Pause the video and carefully scrutinize Table 28 summarizing drug therapy options for treatment and prevention of constipation. Pause the video and carefully scrutinize Table 28 summarizing drug therapy options for treatment and prevention of constipation. We will now discuss irritable bowel syndrome, abbreviated as IBS. Let's begin with its definition and pathophysiology. 1. IBS is considered a functional GI disorder. 2. The definition divides IBS into the following subtypes: A. Diarrhea, predominant IBS, abbreviated as IBSD. B. Constipation predominant, abbreviated as IBSC. C. Mixed IBS, abbreviated as IBSM, features of both IBSD and IBSCD, unclassified IBSU. 3. The pathophysiology is thought to involve alterations in both CNS and intestinal pain perception, alterations in GI motility and secretion, and contributions from current or past psychosocial factors, gas retention, and possibly previous GI infection or bacterial overgrowth. A. IBS is more common in women, lower socioeconomic groups, and patients younger than 50 years. B. Patients with IBS have significant reductions in quality of life and use more healthcare resources. C. Comorbid psychiatric illnesses, such as depression or anxiety, may be present in a sizable percentage of patients with IBS-4. Regarding its symptoms, in addition to diarrhea or constipation, pain is often a component of all subtypes. Other symptoms including bloating, distension, spasm, and urgency may be present. These symptoms, together with the Rome 4 diagnostic criteria that follow, help distinguish IBS from other functional GI disorders such as CIC. B. And now let's discuss its diagnosis. 1. Diagnosis is made by exclusion. We should rule out other GI causes with a thorough workup. Evaluation of a patient's pattern of symptoms may provide insight into subtype, although patients may alternate between forms. 2. Several diagnostic criteria and scoring systems have been developed, including the Cruise, Manning, and Rome criteria. The Rome 4 criteria are used mostly commonly and are as follows. Recurrent abdominal pain, on average, at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria, related to defecation, associated with a change in frequency of stool, associated with a change in form, appearance, of stool. Symptoms should have started at least 6 months before diagnosis. Guidelines recommend that if other GI diseases are excluded and no alarm features, e.g., weight loss, bleeding, anemia, are present, diagnosis of IBS can be made with confidence. The ACG guidelines also recommend 1. Screening for celiac disease in patients with IBS-D and IBS-M. 2. No endoscopy if younger than 50 years and no alarm symptoms. 3. No routine food allergy testing. 4. No routine checking for small intestinal bacterial overgrowth unless lactose intolerance is a concern, despite dietary intervention. Let's now look at the treatment strategies. 1. Treatment involves a mix of drug, diet, and psychosocial interventions. Cognitive behavioral therapy, dynamic psychotherapy, and hypnotherapy have all shown effectiveness in IBS-2. Dietary intervention involves avoidance of foods that trigger symptoms. 3. Drug therapy should target main symptoms and possible psychiatric comorbidities. Combinations of drugs may be necessary for maximal effectiveness. Treatment of IBS-M should target the current symptoms. Antispasmodics. They are used mostly for short-term relief of abdominal pain, but also to treat diarrhea in patients with IBS-D. They can be used on an as-needed or scheduled basis. 1. Dicyclamine, marketed as Bentyl, anticholinergic adverse effects. 2. Hyoscyamine, marketed as Levsin, Levsin SL, anticholinergic adverse effects. 3. Peppermint oil, use enteric-coated products. It can worsen GERD, but can improve symptoms in IBS and is superior to placebo. Tricyclic antidepressants, treat pain, improve global symptoms, and slow motility in patients with IBS-D. They can be used in IBS-C but may worsen constipation. 1. Amitriptyline, nortriptyline, and imipramine are the most studied. 2. Doses cannot be raised enough to treat comorbid depression. 3. There is potential for anticholinergic effects, sedation, cardiovascular effects, and drug interactions. Selective serotonin reuptake inhibitors, abbreviated as SSRIs, treat pain and improve global symptoms similar to the use of tricyclic antidepressants. SSRIs are used for both IBS-D and IBS-C. 1. Fluoxetine, sertraline, citalopram, and paroxetine are all viable options. 2. They tend to have a prokinetic effect, therefore, they can also improve constipation in IBS-C, however, they can also be used for IBS-D, especially if comorbid depression or anxiety exists. 3. Adverse effects include insomnia, sexual dysfunction, and withdrawal. Laxatives can be used for IBS-C. 1. Psyllium has the best evidence, however, it can cause bloating and gas formation. Calcium polycarboxyl can be used as an alternative bulk-forming agent. Wheat or corn bran should not be used. 2. Polyethylene glycol-based laxatives Mira-Lax can increase stool frequency, but they have no effect on reductions in abdominal pain and overall symptoms in IBS. There is minimal to no bloating. 3. We should avoid stimulant laxatives because they can worsen abdominal pain. Lubiprostone Amitiza is approved by the FDA for IBS-C in women older than 18 years. 1. It is a chloride channel activator, improves motility and possibly pain. 2. It is dose at 8 micrograms twice daily with meals for IBS-C. 3. Nausea and diarrhea are the main adverse effects. 4. It is costly as well. F. Linaclotide Linzess is approved for IBS-C. 2. Guanylate cyclase C agonist increases fluid secretion and decreases transit time. 3. Dose is 290 micrograms orally taken once daily on an empty stomach 30 minutes before meals. 4. Common adverse effects include diarrhea, abdominal pain, flatulence, and abdominal distension. G. Plecanatide, marketed as Trulance, is approved for IBS-C. 1. It is a structural analog of uroguanilin, an endogenous guanylate cyclase C agonist, causes an elevation in intracellular cyclic guanosine monophosphate C, GMP. It stimulates secretion of chloride and bicarbonate into the intestinal lumen through activation of the cystic fibrosis transmembrane conductance regulator ion channel. Decreased activity of pain-sensing nerves appears to occur because of elevated extracellular C-GMP concentration. Clinical relevance of the effect on pain fibers has not been established. 2. It is dosed at 3 mg daily without regard to food. 3. Its common adverse effects are mainly GI-related. If severe diarrhea occurs, discontinue plecanatide. 4. Counseling points. It may be crushed and administered in apple sauce or water, or by feeding tube. It is dispensed in a monthly blister pack. H. Tegaserid, marketed as Zelnorm, is a serotonin 4 partial agonist that is approved by the FDA for IBS-C. 1. It improves pain, global symptoms, and motility. 2. Available on an emergency use basis for situations that are immediately life-threatening or that require hospitalization only because of its association with the development of cardiovascular events in women. 3. Requests for use must be approved by the FDA. Use will be denied in patients with history of cardiovascular disease, diabetes, age 55 years or older, depression or anxiety disorder, or at the discretion of the FDA. Loperamide has no effects on global symptoms or pain, but reduces motility and increases stool consistency. May be used as an adjunct to other therapies in IBS-D. J. Alushadalin, marketed as Vibertc (CIV), is FDA approved to treat IBS-D1. It is a mu-opioid receptor agonist. 2. It is dosed at 100 mg orally twice daily. We should reduce the dose to 75 mg orally twice daily if the patient has no gallbladder, or is unable to tolerate 100 mg. Concomitant OATP1B1 inhibitor e.g., cyclosporine, gemfibrozil, antiretrovirals e.g. atazanavir, lopinavir, ritonavir, sakinavir, and tipranavir, rifampin, L-trombopig, or if the patient has mild to moderate hepatic impairment. 3. It can cause sphincter of Oddi dysfunction. Its counterindications include biliary duct obstruction, alcohol abuse that is greater than 3 drinks per day, history of pancreatitis, child Turcotte Q class C, severe constipation, or GI obstruction. 4. Discontinue therapy if constipation lasts for more than 4 days. K. Alozatron, marketed as Lotronex, is a serotonin 3 antagonist that is approved by the FDA for IBS-D. 1. It improves global symptoms and reduces motility. 2. It is associated with the development of colonic ischemia, therefore, available only through manufacturer prescribing program. L. Regarding probiotics, some evidence to support improvement in global symptoms, bloating, and flatulence. There is not enough evidence to recommend specific strains. M. Antibiotics. A short course that is 10 to 14 days of non-absorbable antibiotic can improve global symptoms of IBS, especially bloating in IBS-D. 1. Rifaximin dosed at 550 mg 3 times daily for 14 days has FDA approval for IBSD. 2. There is limited data with neomycin and metronidazole. Thank you.